Good morning. I'm calling this Performance Oversight Roundtable to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 26, 2025. The time is 9:30 a.m. Today, we will discuss the performance of DC Health for FY 2024 to FY 2025 to date. We'll only hear from our government witnesses today, Dr. Ayanna Bennett and the DC Health team. We heard from the public witnesses on Monday. And we have some follow-up questions about the testimony today. As a reminder for the public, the deadline to submit any written testimony for the record for DC Health is March 12th at 5:30 p.m. Just a reminder, DC Health promotes health, wellness, and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. With approximately 740 FTEs, DC Health is organized into 6 administrations: Agency Management Program, the Center for Policy Planning and Evaluation Administration, Community Health Administration, the Health Systems and Preparedness Administration, the Environmental Health Administration, and the HIV/AIDS, Hepatitis, STD, and TB Administration. The committee did send written pre-hearing questions to the agency and will reference those materials today. If anyone watching would like to see those materials, they can be found online on the DC Council website at dccouncil.gov/hearings. I don't see any of my colleagues who are here at the moment, but I'll certainly turn to them should they arrive. It says call up, but you're already sitting here. Dr. Bennett to provide some testimony, but before you get started, I need to swear you and your team in. So anyone who may speak today, and I know the folks can't see, but she brought a crowd, her own hype team, if you will. If you could please raise your right hand. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right, Dr. Bennett, when you're ready.
Good morning. Chairperson Henderson, council members, when you come, I know you're watching, and staff of the Committee on Health. My name is Ayanna Bennett. As you know, I'm the director of DC Health. On behalf of Mayor Muriel Bowser, I'm pleased to be before you to discuss DC Health's performance in fiscal year 2024 and 2025 to date. Firstly, I'd like to acknowledge the selflessness and hard work of our first responders, including DC Health's emergency management staff in the last few months. Our team has served DC through the presidential inauguration, President Carter's funeral, extreme weather, and the tragic midair collision over the Potomac River. It's been a hard few months, and we are keeping the families and others affected by the crash in our thoughts and prayers, and encourage all those affected to reach out to crisis services if they need them. These events were supported by our new Health Systems and Preparedness Administration. We call it HISPA, which launched this fall. Last summer, I reorganized our agency to better realize Mayor Bowser's vision of a comprehensive health system for the district. Our new structure merges all of our health system functions into one administration. My goal is to ensure that all residents have access to high-quality, patient-centered healthcare by attracting needed healthcare professionals and facilities, supporting robust coordination across healthcare entities, and maintaining system-wide resiliency. We're particularly proud of our successful partnership with the DC Hospital Association and DC Fire and EMS to reduce ambulance patient offload times at our hospital emergency departments. This has been a significant concern to health facilities and first responders, as well as negatively impacting patients. Comparing this January to January of 2024, we've seen a drop in the longest offload times from 1 hour and 30 minutes to 1 hour and 7 minutes, and we expect further improvements to come as that program continues. DC Health also launched a new Environmental Health Administration, EHA, in late 2024 to expand our capacity to protect residents from health hazards in our environment. The work of EHA includes the existing work of the food, hygiene, radiation, and animal services programs. The emerging programs will include work to reduce hazards in the home and mitigate health impacts of climate change. The full scope of what EHA will do is being developed in active partnership with community groups and other city agencies. I've also made multiple changes in our administrative leadership to help us reach our highest level of efficiency and effectiveness. Last year, I moved the Office of Health Equity into my central office to redirect its work towards ensuring that the programs and resources of the department are focused on eliminating health disparities and working with communities. This will strengthen our capacity to achieve outcomes for our residents that are both meaningful and equitable. Finally, I have brought on 2 new leadership staff, the agency's first health informatics officer and first chief performance officer. The chief health informatics officer will work to enhance the accessibility and interoperability of data, allowing for more advanced use and improved data sharing with the public and with partners. The chief performance officer will lead our quality improvement efforts to increase efficiency across the agency and identify high-impact goals that we can achieve through our work. These efforts will strengthen DC Health's capacity to work with council and the public to recognize important health concerns and identify key initiatives to support through funding and partnerships. DC Health is now better positioned to commit resources and apply creativity to our core mission, achieving concrete health improvements for district residents. While the news in recent weeks has left many uncertain about the future of public health, I'm incredibly proud of the success of the DC Health team and our partners over the last year, and I want to share these achievements as a model of how we intend to go forward. I'm pleased to announce that our cancer control team within our Community Health Administration has made significant improvements in the quality and timeliness of breast cancer care for residents who are seen in our community clinics. The team noticed in 2023 that women who got abnormal mammogram screening results were waiting far too long before engaging with providers to plan for their care. This delay stemmed from multiple factors, many of which were social needs or clinic processes that patients could not control. The team worked with the DC Primary Care Association and providers to improve the screening process, expand and streamline referrals, provide practical resources to patients, and standardize patient navigation. These efforts decreased the average follow-up time for abnormal mammogram screenings from 68 days in 2023 to 28 days in 2024. That's 40 fewer sleepless nights for patients waiting to hear if they have a cancer diagnosis, and less time for any potential cancers to grow unchecked. Our new Environmental Health Administration, which works to eliminate health hazards, stood up a new bedding and upholstery program last year, protecting residents from inadvertently bringing bed bugs or other pests into their homes. This is a protection that is longstanding in other states, but that DC has lacked until now. The new program registered over 2,000 businesses in fiscal year 24 to ensure that they met standards for storage and labeling of bedding and upholstery products. District consumers can trust, just as they do with the swimming pools and restaurants we inspect, that DC Health will ensure that these products are safe for their use. In addition, I'm excited to announce that within the next couple of months, our Environmental Health Administration will launch the Carbon Monoxide Protection Program, which will provide education and really sensitive carbon monoxide detectors to our most vulnerable populations, the elderly and families living with children in wards 5, 7, and 8. Mayor Bowser earlier this month recognized the significant improvements that we have made in reducing the transmission of HIV. At last count in 2023, DC has reached the lowest annual total of new HIV cases since the 90s. Over the last 15 years, DC has seen an 85% drop in new HIV cases, and our partnerships with community-based organizations and clinical care providers have helped rapidly connect residents newly diagnosed with HIV to care, over 80% of them within 30 days. Due to these efforts, 88% of clients living with HIV in DC in 2023 achieved an undetectable viral load, and therefore will not pass HIV through sexual transmission. In closing, I look forward to keeping the council, our partners, and the public informed as we continue making improvements to keep our residents safe and healthy. I thank the council and the committee providing DC Health with an opportunity to discuss our work over the past year and our vision for the future. I'm here with the DC Health team of innovative public health leaders, and we are all available to answer your questions. Thank you.
Thank you. And I will say, I want to join in expressing my thanks to the folks. It's hard to believe it's only February. I feel like January was like 20 years
A year of a
long.
month, yeah.
And so, yeah. My staff gave me a lot of questions.
Okay.
Let's see where we go. 81, to be exact. With sub-questions. But it's always good to have an opportunity to check in. I think the number one thing when we were reviewing sort of the background documentation and things yesterday, I was like, God, y'all do a lot. A lot.
I was with the other 35 big health departments in the country, so the Big Cities Health Coalition, and describing DC Health because they come to visit, and they were a little gobsmacked by how wide our scope is. It is
Yes.
different than everyone else.
Yes. Okay, so let's get started. I want to first start by asking some questions that were follow up from some issues that were raised during the public testimony on Monday that don't necessarily fit in any sort of other category, but I want to make sure that they get asked and that they don't get lost. So we heard from a parent of a child with a chronic medical condition that raised concerns about DC's Health's lack of guidance and reporting related to COVID in conjunction with what I think has been a very tough flu season, at least from what I'm hearing from the hospitals. Could you, when is the last time DC Health has updated the website with regard to COVID guidance?
I don't remember when the last time was, but we last updated it when there were any real changes, and that has been quite some time.
Okay.
The recommendations, both from the CDC and our own look at the situation, have been fairly stable for quite a long time now. The recommendations for kids who have an active infection are not so different from COVID versus flu versus anything else. We want to keep all of these infectious respiratory viruses out of schools as much as we can. And so there are recommendations that fit all of them that are recommending that people stay home, that they don't come when they have symptoms.
I think more of the concern was around, is DC Health still doing the wastewater surveillance management? And should there be elevated signs, will we alert?
We do still watch. That is one of our roles, is that we keep watch on the state of where things lie. We're watching our wastewater, and I still get reports about where we stand with COVID. At the moment, flu is much more our problem than is COVID. We're having a nationally very terrible flu year. And so we are looking at that, but we have always remain vigilant about where the numbers are going.
Okay. We had quite a few public witnesses who testified about establishing the Office of Black Men's Health within the agency. I wouldn't necessarily know if we need sort of the race modifier, but just sort of this idea that men's health has sort of been lost in the conversation, and that there might need to be an office that is particularly focused on raising public awareness about the particular health challenges that men may face.
Yeah. I agree with them that we do have a problem with the health of men in our community. I think one of the things that happens is we're talking about an issue more generally without ever naming that the people who that is happening to are men. So our overdose epidemic that we are just slowly getting some control over is happening not exclusively to men, but overwhelmingly to men. A lot of our deaths and early demise from smoking or other chronic diseases is happening first and most extremely to men. So our work that we are moving into and have been doing to some degree for years, but plan to elevate around chronic disease, looking at the health of our unhoused population, those are all going to be delivered for the most part to men. I wouldn't make it exclusive because you don't build a system and then close its doors to other people, and we can't predict what the population will look like or do. But the needs of men will have to be in the forefront. We have to design something so that the people who are most affected by it are able to use it. And so that is what we will be doing, looking at the needs of the men who are suffering from these different conditions and how can we shape our programming to fit that. I'm happy to talk about that in terms of the state of men's health. I think that is, I really want to be able to talk about population so that people can see themselves in our data and understand what we're doing for them. But that we're still working on that. And I'm happy to, we've been talking to all of those folks about what that might look like.
Okay. I am not necessarily convinced that there needs to be an entire office dedicated, as in, there are a lot of cross-cutting work, but
Right.
perhaps it is about specific types of messaging, trusted messengers, because I think we did have a witness who was like, yeah, I didn't even listen to my wife. And I'm like, okay, so I'm gonna spend government money for you not to listen to us too. And so just trying to figure out how do we elevate those pieces, because I think as you talked about, particularly around opioids, that was certainly true in terms of who was overdosing and who was dying. It was a very specific population, and we needed to target our messaging in that way. But there are, a variety of other things as well, which from the public health side of things, perhaps our messaging just needs to be a bit tighter.
I think part of what we know from COVID and just as a best practice in public health over many decades is that you have to be talking to someone. What general messages don't really work very well. They work to some degree, but people have to be able to see that you're talking to them. That is a communications issue, and we are working very hard to improve our communications, to make sure that we're working with community, to make sure that the messages that we're sending out fit them. I do think that there needs to be some specificity in programming.
Okay.
And that usually at its best is a layered approach where people can find the fit of a program that works for them, but it's not the only way to interact with that program for people who that is not the right fit for. We are already doing that in many things, but we plan to do that more. That targeting really is the best practice of how do you get people to move into something. There are lots of, I think, fairly well worked out strategies for working with men, working with Black men in particular. There are successful projects around blood pressure, around mental health that do work. So it is not as if we can't do this. We just need to put some focus to it, and that is part of what we've been planning, specifically around hypertension and some other things. But I think when you get the approach right, you can expand that approach to fit other conditions.
Okay. You mentioned in your testimony that you moved the Office of Health Equity under your office and have shifted their priorities. What outcomes are you measuring in terms of assessing the impact of their work?
So the work is multi-stage. So part of it is, at the baseline training our staff, and I don't mean training them about equity, but skills training around how do you translate a desire to have health disparities decrease to the way you treat your data, the way you look at how you program, and we're still moving forward on that. The outcomes I want are health disparities to decrease. So I want actual tangible outcomes that our population can feel. In the meantime, the process that we'll go through should be evident in the ways in which we display and talk about data. We should be disaggregating data and understanding, everyone should be able to understand where the disparities are in the populations that they're looking for. Everyone should be able to have goals that both address the problems in aggregate, but also are very specific about who is this problem happening to, and that we have specific goals around decreasing gaps, both in individual conditions, but in our big life expectancy gaps. I want to see equitable outcomes for everyone, and we should have that as a deliberate goal. So looking at our key indicators, how we use them, looking at our data and how we share it, those are the outcomes that you'll see that are the process that we're going through, but the real final outcomes that'll tell you whether it's working or whether or not we actually are seeing changes in health disparities.
Okay, I recognize that you're doing some shifting, but I also want to note that this office has a very high vacancy rate. It's 12 FTEs that are assigned to him and 8 are currently vacant. So how are we filling these positions to do this great work?
I think some of those are grant positions where the grant has run out and therefore the project has ended.
Okay.
Is there any that aren't? There's one or two that are somebody has moved out and we need to replace them. But what they had done in the past is and we will do some of in the future, is do projects that were grant funded, staff would come on to do that, and then the project would end. I'd like a more sustained internal improvement work approach. And so we will be looking at positions, but I don't think the size of it is the most relevant element. I want the changes in people's work to happen in the work we're already doing.
Okay. So as I mentioned at the top, you all have quite a few FTEs. Perhaps I think healthcare finance maybe have a little bit more than you do. You all completed 89% of the performance evaluations for your staff, which is good, but not 100%, but nonetheless, it is what it is. Interestingly though, out of these, there were 0 performance improvement plans issued. Does the agency have a policy of not issuing PIPs, or is everyone just doing such excellent work that no one needs one?
Well, the PIP is the end point. So you can have done quite a lot of coaching and counseling and improvement work before you got to a PIP. A PIP means all of that failed. So what I'd like to believe is that we're successful at retraining people and getting them back on track when they fall off track. And then there are people who just choose, once they've learned that the job is not what they are doing or not what they want to do, to not stay. So I don't consider the absence or presence of a PIP to be a very good indicator of whether or not we're doing management of our staff, because that means you have failed to manage them all the way to the point where now you need a PIP. It's progressive, right? And that's the end of the progression.
Yeah, okay. So as part of the testimony yesterday, we heard from a number of students from the Crittenden program. Interestingly enough, having to come testify because their grant got cut in order to pay for expenses for the new animal care and control contract. For context, for those who are just tuning in today, EOM required DC Health to identify and reprogram approximately $6.5 million in your agency budget in FY25. When I asked EOM about these reductions in January, the mayor's budget director informed us that at least some of these funds will be restored in the supplemental budget. What is your current understanding of what funds will be restored?
I think we have to know for sure how much. Some of the funds are for individual food programs or other things like that. I would want to look at where we are at the time before saying that. I will say that individual programs that are carved out for individual organizations, and that is what happened with the one with Crittenden. It had been carved out at some point in the past by, I believe, a member of council. I'm not sure who, but it was not a established priority of the department. It didn't attach to anything else in the department, and it wasn't run as
Teen
a
pregnancy is
competitive-
not something you guys do? Teen pregnancy prevention?
Let me finish. And it was not connected to a program that was a competitive bid that they were doing some part of. So we do teen pregnancy in that we run school health, a separate program. We should decide whether or not that's what we need to do, and we will do that. And if that is where we need to go, and of the many, many priorities that we have that we can't all fund, we'll have to look at which ones we're able to fund and which ones have the biggest impact.
Okay.
And impact is the measure, not anything else.
Hear you on that. But as the federal government is also having this debate of who appropriates versus not, we are similarly having that. And so if we wanted to have the debate about whether or not the Crittenden grant should continue, we should have talked about that last spring, not in the middle of a school year. As you can imagine, that's difficult for a nonprofit organization who has planned. But also beyond just Crittenden, I'm surprised that you didn't say we are definitely restoring the school health grant, because you all promised Children's that you would.
We are definitely restoring the school health grant, but there are others parts of that which I don't know for sure.
Okay. And so there were some other investments as well Get Check DC, STI funding, about a half of the funding for that was cut. The High Needs Healthcare Scholarship, $500,000 from there was cut. An emergency childcare pilot program that the mayor put in after conversation with us, that was also cut as well. So I'm not putting this all on you. Obviously, you were put in a very tough situation.
Did we had to do.
But going forward in sort of these conversations, when we pass a budget and then there are cuts that are made mid-year after organizations and others have made decisions about how to move forward, that's very difficult for us to do. And so we'll be talking more about that during the budget process. I guess that was.
It was regrettable, and I'm really do feel how difficult that was. I ran a nonprofit for many years. It is hard to run a budget.
Okay. Let's talk a little bit about school health services. We heard from several public witnesses about their desire to improve the cluster model that's currently being used. What changes has DC Health already implemented with CSS to try to make operations better this school year?
So we have worked with them on the protocols that go into deciding how the model operates, the system that decides what level of staff goes to which site, and just the constant oversight of how they're staffed at any given point. There are more changes that need to be made in terms of building better programming about continuing education and oversight of the staff in the program. They have done some of that and brought on trainers and done some building on that area. We have hired on people to build further in that area to increase the quality.
Okay, so in the budget process for FY25, council moved about 1.4 million to DC Health to enhance the school health program, including contract staff and learning materials for the administration of medication training. In September 2024, DC Health reported that all 10 contract staff had anticipated start of Q2 of FY 2025, but in the pre-hearing responses that you all submitted to the committee, you report that there are only 9 positions and none of which have been hired. What's the delay?
I believe 4 of which have been.
Robin, if you could just introduce yourself for the record.
Sure. Good morning. I'm Robin Dix-Purdue, Senior Deputy Director for the Community Health Administration. So we do have 2 of the nursing staff on board now. We also have a Chief Medical Officer that has joined our team as of this week. And we are continuing to recruit for those contract positions.
Okay, are they posted somewhere?
They're with a staffing agency.
Staffing agency
Yes.
positions,
Mhm.
okay.
Mhm.
Okay, so you also reported in September 2024 that the anticipated rollout for the new learning materials and learning management system is April of 2025. Is that still accurate?
Yes, we're on track. We should have those contracts in place by March and then be able to launch on time.
Okay, and so how will that work in terms of letting schools know that this is available to them before the end of the school year?
So we're going to start our communications campaign around March 2. Training will be occurring over the summer. And then like the official, launch date is around July.
Okay. We heard on Monday from some witnesses from schools, that slots for AOM have been restricted. One person mentioned that they felt that it was cut by about 50%. Is that accurate?
No. So I would say there's about maybe 10 fewer slots available this year compared to last year. We have 2 opportunities per month, so about 60 slots a month available. Part of the issue is that folks are not completing the online training models in time. And you have to complete those before you can actually move on to the in-person portion of the training and certification. Right now, about 50% of the staff have started the online training modules, but have not completed them. It's over 80 staff right now.
Okay. I don't know if you watched the hearing or perhaps some of the staff did. If you could follow up with that LEA.
Yes.
Okay,
Yes.
that would be
Yes.
great. Thank you. So the committee did ask for some data about the total number of day callouts from the school health suites. And DC Health reported that for school year 23-24, that almost 1,900 reported schedule changes. So now only 573 were replaced by an in-person substitute.
Mhm.
Do you feel like that's an acceptable replacement rate?
No, but we're still making improvements in the other coverage was phone coverage by the nurse managers to provide support to the schools where we could not have, an in-person replacement. But we're continuing to work through that.
Okay, what does data look like for this school year? Are we on a similar trajectory in terms of callouts?
Yes, but I think we're a little bit more improved in terms of the coverage.
Okay. The responses showed a 35% vacancy rate for LPNs in the cluster. Now I know LPNs is a little bit different. It's a little bit trickier because we don't have as many LPN training programs as we do for RNs. I don't know. Does recruitment look different for our LPNs versus RNs in terms of the high vacancy rate here?
I mean, we have a significantly lower number of LPNs in the district compared to RNs. So, I think it's under 5,000 total. So that is part of the challenge. But the recruitment efforts are still ongoing, and we are continuing to explore, other recruitment opportunities like retention bonuses and or recruitment bonuses and those types of things.
Yeah. Director Bennett, we had a meeting with Chairman Mendelson about school nurses in particular, and I know that it is, you can't necessarily speak to future plans for this. But can you describe whether or not you think that this model is working?
So I think the model of having a nurse who is responsible for multiple schools and has nurse assistants at those schools is a viable model, and I think it does work the vast majority of the time. The reason I believe it's the right model is partly because the pace of work at the schools makes that make sense. You've got, most schools have less than 10 kids in a day. So that's 1 or 2 kids in an hour. So you do have time for them to consult the nurse if they need to. The vast majority of those are routine appointments where somebody's getting a medicine that they have been directed to get that you gave them yesterday. So I do think there's more than enough room for people to consult with a nurse. I do think we need to strengthen the programmatic ties that make them a team. So the number of times they contact each other, how much they see each other, how the nurse actually physically gets from school to school, those are all things that I think can be strengthened. But working in a team to support a larger number of patients, particularly when you are doing a lot of routine work and the need for the more expert work is intermittent and spread out, I think this is the way that you do that. Having a fully trained nurse who really interacts with just a few kids during a day is essentially a way to de-skill that nurse. I'm not sure what the value to the greater system would be when we've got such a terrible shortage. I think it'd be a hard job for us to get filled adequately and consistently.
I think one of the issues, as we sort of talk to some folks who work in these suites and otherwise, is that because we have not done what we're supposed to do on digitizing the universal health certificates, the vast majority of these individuals that we're paying to sit in our health suites are doing data entry, basically. So the rate of entered universal health certificates on file is incredibly low. This is based on the data that you guys sent. Out of 84,000 children, we have 3,930, or less than 1%, who have a universal health certificate on file this school year. I thought that couldn't possibly be right, because if we're doing no shots, no schools, how would you all know if you don't have a UHC? unless we're checking the immunization database
We are.
to determine. Okay, so then what's the point of the UHC? Besides parents having to turn in a piece of paper?
The point is to get updates in the condition of kids on a yearly basis. I think we can discuss whether or not it has a value if it's not coming in. I do want to go back to the administrative work that the staff at the school are doing. I don't think they're doing that administrative work in sacrifice of care for children.
Oh, I'm not suggesting that at all. But I'm saying when you said, well, if they're seeing about 10 kids a day, then the vast majority of your time is spent doing what?
Well, we want them to do training, we want them to do other things, but they do have to do something that is useful to the program. I think getting the UHCs in is a valuable thing for them to do. Documenting what's happening with the children in your school is actually, I think, a pretty central part of their job.
Yes, a couple of years ago, Dr. Bennett, this was before your time, and I think there might have been a different director of CHA. You all were supposed to be working on electronic.
We are still.
It's at least 3 years now at this point.
Yeah.
I feel like we've been talking about it for 5 though.
Yes, so we are highly dependent on working with our health systems partners and their technology systems to really make that work. We are still planning with them on that and working with them on that. The timeline within which they can be ready on their end, though, is still a little up in the air right now. One of the things that we're working on in the meantime is collaborating with DCPS on their electronic system so that parents can have the opportunity to upload the universal health certificate electronically along with the other health forms that they can now submit electronically. And then our health suite staff can have access to that data.
Is it upload electronically and then it is in some database or system? Or if someone at the health suite is going to have to go through each
They
PDF?
will have to go
They
through
will
it.
still have to go.
So
through it.
just to clarify, when we're talking about the electronic form, we're not talking about the parent or a separate system that we're asking people to log into, because that wouldn't really function very well. We're trying to get the electronic health record that already exists to add this form. So we're asking companies that are not us
Right.
to make changes in their own systems, which has not been as simple.
Have we
for
done
us.
the reverse of looking at the UHC, which I don't feel like has been updated in at least a decade, to determine whether or not we're duplicating in terms of questions, right? Asking weight and height, I'm sure is in an electronic health record.
It is. And it would automatically fill if the form was in their electronic health record. So that is part of the reason to have it in there, in that it would auto-populate lots of these things and that we would get more of them. Whether or not we need the forms as often as we do, whether or not we can get them electronically and when we want them electronically, I do think is worth some conversation, because there are times when it is really critical to have, and there are times when it is less critical to have. So there are times when we have immunizations, they're not scheduled to be every year, right? There are times when we need them. We need them when something changes. So there is some refinement that can happen in the system, but some of these challenges are just because the thing itself is complicated.
Okay, I'm sticking on this universal health certificate piece because I just don't understand. Honestly, I thought that this was a mistake. Last year, we had about 50% of the students who turned it in, and this year it's less than 1%. That's the part that I'm confused. Is your data wrong, or what happened? Did we just say to schools it doesn't matter anymore? And if so, like, let me know so I don't have to pay for my pediatrician to fill out this form. Because that's, some of these pediatrician offices require parents to pay to fill out this additional form, for which then nobody looks at.
So the parent, there are not enough submissions of the UHC. However, people can also submit their immunization record separately. So I think a lot of parents are submitting the updated immunization records, but may not provide an update to the UHC. And that's another reason why we're trying to explore with OSSI the utility of actually requiring the UHC to be submitted every single year. That's not typical for jurisdictions to do that. And so it may just be a situation where we need a policy change to say we only need an update to the UHC. It's not something that needs to be done every single year.
Okay, you say we are exploring with OSSI. What does that mean?
We're having discussions about the policy.
Active discussion? So like
Yes.
when I go talk to OSSI
Yes.
next week,
Yes.
they're gonna say the same thing?
Yes.
Okay.
I have physically been in meetings about it.
Okay.
I do want to say that it's not that no one looks at it, because that is where we get some of the data we use to decide the severity of the issues that kids have at a particular school. So it is part of our data set that we do use.
Mhm.
We could possibly get that data from other places or in a different way from the parents who it is actually relevant to. So it is definitely worth the discussion, but it is not unused at the time.
Okay. I just feel like for students who have particularly tough conditions, and I'm going to ask some questions about whether it be the asthma action plan or a diabetes action plan.
Mhm.
If we could have our nurses or nurse techs focus their attention on getting those families where we know that child has that condition
Mhm.
to get their action plans in, I feel like that's
Yes.
a better use of
Yes.
time per se. And then of course, obviously checking on immunizations, but if there's an entirely different registry for that, I'm just trying to understand this piece of paper that I hold on to that I had to submit 3 times for one of my kids because the school kept saying we didn't send it. And then I'm like, then what's, I
I
am one
believe
of
all
3,800.
All policies need to get looked at periodically, and this one has been around a while.
Okay. Speaking of that, so DC's Health's data on medication action plans show that 62% of children with asthma have an action plan on file. 82% of children who we know who have diabetes have a diabetes management plan on file, which is good. Only 29% of students with known anaphylaxis have an anaphylaxis action plan on file. What strategies are we using to increase these percentages? And should we be talking to the pediatricians and providers to have these conversations with their families around, hey, little Johnny is going to go to school and little Johnny's probably going to go to recess. Little Johnny has asthma. Let's do this plan and submit this to the school. So if little Johnny has an attack, they know what to do.
Yes, we do need more involvement. I also think we need to talk to the provider community, because things become not standard practice, even though we decide we need them. They're not necessarily, we need to be in agreement about what the utility of all of the different plans are, and what we want them to say and the way we plan to use them. And if you're not communicating that with providers, then it doesn't have the same importance to them maybe that it has to us.
Do we have templates of these action plans? Or is it every provider
Yes.
for themselves?
No, it's a template.
It's a template, okay. And is the template, can it be found on the DC Health website? So if a parent wanted to,
Yes.
yes, okay.
Yes. And it's part of the role of the health suite staff to also follow up with parents about and do some of that care coordination with the parent as well as the healthcare provider around getting some of those forms.
Okay. So the council fully funded the Access to Emergency Medications Amendment Act of 2023 in the FY 2025 budget. You guys told us you needed some FTEs. We need FTEs for everything. You reported that the FTE hired to administer the legislation would be hired in Q2 of FY 2025. Has that position been filled?
Okay. That position has not been posted quite yet. The position description had to be reclassified, but it should be posted very soon.
Okay. Let's see, this is why I give your colleagues a hard time when they tell us they need positions for everything, because we give y'all the positions that nobody hires them in a timely fashion. Okay, what's the status of the procurement of the medication or medication storage? Has the RFP been published?
Yes, that should be executed in March.
March. Okay, we'll check in during budget. You all reported that the program will be fully up and running by April. Are we still on track for that particular timeline?
More like July, to include the training and all of those pieces.
Okay. I want to ask a little bit about school-based health centers because it seems as though you guys did something a little bit different than what we talked about during budget. My understanding that, well, actually, no, I'll take that back in terms of reclassification. You didn't do something different, but during budget, you guys didn't necessarily have a full-on plan of what you were going to do, although we were reducing the amount of money that was available. So while I think people might have thought you were going to be taking some of the sites offline and just focusing on a couple, it seems as though all of the school-based health centers are still operating, but they've just reduced their hours. So now doing 2 to 3 days a week, as opposed to being there 5 days a week. Are there no health staff at these schools when these centers are closed? So, yeah, that's my question.
There's health suites. There are always health staff. The clinic is not open though. So
Okay.
there's not the full services, but the standard services that every school has. they
Yes,
have.
that's my question.
Yes.
Okay, so those are continuing. Okay. How does that work in terms of scheduling? And by that I mean, so a lot of our school-based health centers are at high schools, for instance, which have in some cases, much larger number of young people than say at an elementary school or at a middle school. Are we confident that when the clinic is closed, that if there needs to be, say, a nurse at Jackson Reed is not one of the locations, Cardozo, that there is a nurse that's there?
So the health suite functions of giving kids their medication, et cetera, those continue. What the health centers do is much more a doctor visit kind of level of care. So it's not the same level of care. I will say that the medical needs of a high school and of an elementary school are quite different.
Yeah.
Kids use their own asthma inhaler. They carry, people at 16 or 17 take care of a lot of things by themselves that we do for kids in second and third grade. So the demands of the job are different, which is why the health centers are there. They have more complicated needs. They are trying to independently take care of their own care. So it's a little bit of a different story of what the nurse is needed for at those schools.
Okay. I just wanted to make sure that the clinic was not taking the place of the health suite. And so that's good to know.
It is not.
All right. I want to ask some questions about nutrition and healthy food access. So DC Health has been a partner with DHS and OSSI this year to do the Sunbucks program in the summertime. We didn't pick the name, but it is what it is. It is. You all weren't involved last year, so I'm curious in terms of what work you all will be doing this year as in support of this program.
I'll let my subject matter expert come up and talk a
Okay.
little more about this.
Good morning. My name is Sarah, and I serve as the Bureau Chief for the Health Promotion and Disease Prevention Bureau. Last year, we did some outreach, and this year we will serve as the operator of the call center. And then we will also be doing outreach and marketing.
Okay. As operator of the call center, I'm assuming you guys are going to contract that out, or is that going to be in-house?
We will do it in-house.
Oh, okay.
So we're currently executing the MOU with OSSI and DHS and DC Health. And so that's going through, it's on its way to Dr. Bennett. And yep, we will do it in-house.
Okay. I was happy to see that the WIC enrollment increased
Mhm.
by 7% in FY 2024. In your responses, you listed some of the potential reasons for the increase, including using a federal grant to increase the location and hours of the WIC clinics. What do you feel has been most effective in increasing enrollment participation?
We made a concerted effort to get back to the basics and support TA for all of our 4 grantees. So they have staffed up all of their clinics. And when they were at a good place, then we were able to, my team has applied for numerous funding opportunities. And so we have a workforce development grant where we have trouble recruiting and retaining our dietitian staff. So we are paying for our current employees to either complete their dietetic internship or complete their undergraduate or master's degree to then be eligible. We've also have a data sharing and outreach grant that I'm really excited about. So we've been talking about how do we streamline the certification process. So we applied for a grant in partnership with the Department of Healthcare Finance from Johns Hopkins. And so we have had our first planning meeting to I can't tell you right now what that solution will look like, but we are working through the springtime to somehow make DCAS and our WIC eligibility system talk to each other.
Wow, I just had that hearing on healthcare finance and good luck.
Thank you.
On TCAS. So participation in the WIC Farmers Market nutrition program also increased. It went above 50%, 57%. It's the first time. Did this increase correlate with the overall program participation, or did something else drive the farmers market piece?
That is our partnership with Dreaming Out Loud. And so we have really pushed and marketed the home delivery option. And just continually work to understand what our families need. So this past year, Dreaming Out Loud offered the option, would you like your box to be delivered when you're at home? Or is it okay if we leave it at your home and you're not there? And just continuing to offer options has been helpful.
That's great. And Dreaming Out Loud, they did testify. Actually, did they testify? Jaren testified.
Yeah.
It was like, they also testified at other hearings as well. That's great in terms of the partnership piece. And again, we're seeing this increasing number of food insecurity based on the Capital Area Food Bank's latest numbers. And so the amount that we're able to do to help supplement here, I think is super important. In the responses, DC Health reports that the Commodity Supplemental Food Program, or Grocery Plus, which provides monthly grocery boxes to low-income seniors, has about 1,400 seniors on the wait list. Does the federal funding have a cap, or are we just exceeding our demand?
It has a cap, so that we have a caseload that we are able to serve. So that's 5,700. What we've done successfully is every year we've applied for an increase in our caseload and we have received it. So we will continue to do that. And then we work with Capital Area Food Bank to determine, are there additional programs that Capital Area Food Bank can offer?
Okay.
Yeah.
So our cap is 5,700.
Yes. I'm just gonna keep moving. Okay, so
Dreaming Out Loud currently supplements those boxes with fresh produce through the USDA local food promotion grant. Has this grant been paused, and has USDA communicated to DC Health about its future?
Sure. So this was always a 3-year grant that we applied for in partnership with Dreaming Out Loud. So it's coming to an end.
Got it. Okay. All right. More food. You all noted that the Senior Farmers Market Nutrition Program will lose about $244,000 in ARPA funds at the end of this fiscal year. And unfortunately, 530 seniors will have to be dropped from the program. Have you all considered identifying any other resources to be able to continue this level of funding?
We are able to carry those ARPA funds over into FY25. So for this year, we yes.
I'm talking about in October, when those funds are gone.
Yes, so those ARPA funds will end, and we will look to see if there are any additional federal opportunities that we can apply for.
Okay. So we heard from Monday from DC Central Kitchen about the Healthy Corners program and the Snap Match. And frankly, some of the outcomes for some of these stores is pretty incredible in terms of how it has essentially shifted how some of these markets are stocking their shelves and, wanting to bring in more refrigerated products in order to be able to serve the community. I'm just curious how you all envision this program growing in the future, how we can support it growing in the future. Yeah.
We've talked through creating a tiered, and when I say we, DC Health and DC Central Kitchen, creating like a tiered system that corner stores can, if they reach a certain level of program intervention, they would be eligible for additional funding. So that then we can incentivize a higher level of healthy food within the corner stores.
Okay. All right. So in terms of federal food access grants, I don't like to give the federal government any money back. We ended up having some grant lapses because subgrantees either didn't submit their invoices on time or because of high turnover at their organizations. What is our strategy in terms of stepping up technical assistance on this front? We had to give money back in the farmers market program. We had to give 20% of the funding back for SNAP Ed. How are we going to improve this going forward?
We were able to, some of that was end of year accounting numbers. So we actually did not send back that amount of funds. I know that for Women, Infants, and Children program, we sent back a lot. Mostly that is the food money. SNAP Ed, we did not send back that amount of funds. One of our grants with SNAP Ed, we had some issues with payments and being on time. So we've provided TA to them. So ongoing TA around submitting your invoices on time, especially as we get to the end of the year, that's the time that is critical.
Okay. We heard some testimony from one nonprofit about the challenges with Produce Plus, including cards not working, but also that, gentle way to put this, disparity in terms of marketing certain markets versus others, whereas there might be a market that's closer to you in your neighborhood, but all of the promotion materials with regard to this program are promoting something that's further away in distance. There's some approaches we can do here in terms of direct marketing to balance things out a little bit more, Robin?
And we did notice that we had the updated market list on the wrong place in the website.
Okay.
So we are updating that and then making sure all of our partners have the updated market list as well.
Okay.
So
Have you guys ever thought about doing direct marketing to the program participants?
So Fresh Farm emails and sends through text message a link to the market guide to all of the participants. And Fresh Farm and DC Health, we both operate a farmer's market hotline. And so when an individual calls, we ask you for your zip code, and then we tell you what markets are nearest to you. What we'd like to do this year, so we do this with our women, infants, and children program. We can send targeted text messages. So based on your zip code, we can send a text message. These are the markets nearest to you, and we'd like to do that same approach with Produce Plus.
Okay, that's great. That's good
Yeah.
to hear. We have some legislation on farmers markets. I think we have a hearing in March 17th.
17th.
To help try to improve. The DIMPID hearing is going on right now. But when I have these conversations with Deputy Mayor Alpert, I understand the difficulty of the grocery store recruitment piece of things, but we need to figure out how to plug in these other places. And frankly, I love picking produce from the farmer's market versus the grocery store anyway, because I do feel like the quality is better when you get it straight from the farmer. And I would love for everyone to be able to, and we do have farmers markets in every ward. So I don't want someone to feel like they always have to travel west, or you gotta go, well,
Yeah.
if you're looking for a farmer's market on Sundays, you might have to go west. But the point sort of being is that we all have done a really good job of making sure that we have farmers markets in every community. Now we just need to promote them to ensure that they are sustainable and can continue to work. All right, last question on food for now, because I'm gonna ask about these food inspections later. But the committee funded a new pilot program with regard to grocery delivery for SNAP Ed participants in Ward 5, 7, and 8, 1,000 folks. And I'm curious in terms of if we've been able to execute that agreement and when that program will roll out.
Sure thing. So we are in partnership with an online grocery retailer, currently under an NDA until the contract is executed. And so we've also partnered with MedStar Health and Martha's Table. So we will distribute 1,000 free memberships, and we aim to launch in March. So it'll be 200 patients from MedStar, 200 SNAP Ed participants, and 600 Martha's Table Health and Wellness Program participants. We looked for the most effective partnerships that we could get this money out the door.
Great.
Yeah.
I look forward to that announcement.
Mhm.
And I will also just sort of give a plug. That actually wasn't an idea that originated with us. It was an ANC commissioner in Ward 8 for whom had been getting her groceries delivered because she has a disability. And she said, hey, this might be able to work for my neighbors. And she was the one who brought it to us. So I definitely want to give her credit on that, because
Great.
yes, local government,
Thank
right? You
you.
can come with solutions to problems and see your things implemented. Okay, I want to switch to maternal health. I usually ask maternal health at the end, but let's just be a little bit different here. Okay, so in some of the data that we have received, it's a little bit mixed. So for the preterm birth reduction initiative grants, each grantee received an amount of funding, and some saw great outcomes and others did not. And so I'm curious, as we go forward, each grantee is receiving the same amount of money. I think it's $350,000. Does DC Health sort of plan to augment that grant amount based on performance?
I would say yes. We do have some intensive TA and corrective action plans in place with some of our partners
Okay.
that have been having some challenges. We also now have our state maternal health, innovation project that we're working on. And so there is alignment that can occur between some of the preterm birth reduction projects and some of the other work that we're doing in that space.
Okay. And if folks are trying to figure out what we're talking about, go to the pre-hearing responses. They got all of the information. We do ask these questions. So I'm not going to put these grantees on blast in terms of who is performing not as well as others. But when we're talking about a limited amount of funding, then I think we have to evaluate
Yes.
the effectiveness of some models versus others and provide additional support to those who are doing better, if you will. Okay. In the responses, DC Health reports that the district lost nearly $1 million in federal funding for the Healthy Start program in FY24. Why did we lose that funding? Was that formula funds or grant funds? What happened there?
The federal grantor was unsure whether they were going to continue that program at all nationally, and was going through some changes. And then they made a decision to provide funding to one of our partners. So the program will still be implemented in the district, but we will have, more of a general partnership role versus, the direct oversight of the program itself.
Okay. So we did get funding, but they funded directly the partner organization?
Yes.
Okay.
The organization that's providing the direct service.
Okay.
Yeah.
Had DC Health just sort of been a pass-through in the past?
I wouldn't say pass through, but
I'm just, I'm all for efficiency,
No.
but
We pass through most of the money that comes to us. What we do, though, is retain enough to oversee and to provide technical assistance and make sure the money that comes to us gets spent and we get something out of it.
Yeah.
We don't have that role this time.
okay. Okay. All right. Okay. So, we did hear from several participants on Monday of the nope, wrong program. Ooh.
Yeah.
Healthy Start,
Mhm.
Healthy
Healthy
Steps.
Steps, not
We
the
got to
same
get more creative with our program titles. Okay, we did hear from several public witnesses on Monday about Healthy Steps, which is the program for mothers and their children. How many families are currently served by this program?
I believe it's over 400.
Okay, my second question was going to be whether or not there was a wait list. Like, do we have more who are interested than what we can meet demand?
I'll have to look into that. I don't believe so, but I'll have to look into that.
Okay. In terms of evaluating the effectiveness of this particular program, are we seeing the outcomes that we desire?
We are seeing improvements, over each year, I would say. This year, I think our partners have done a much better job of being able to report on some of the data elements. And so we are seeing some significant improvements.
Okay. In your responses, DC Health recommended sunsetting the Perinatal and Infant Health Advisory Committee and the Lactation Commission, since the agency will now be running a maternal health task force required by the Federal Health Resource and Service Administration. Is there no way for you all to just sort of combine the memberships and call it the task force, or?
We have brought
That's-
many of the same people together
Okay.
as part of the task force.
Yes.
That's why we're saying that.
Okay. What's the scope of the new task force?
It's very similar, right? So the key objectives are really to focus on the disparities that we see in perinatal health outcomes, right? And we plan to have different subcommittees that can focus on different areas. So whether that's severe maternal morbidity, maternal mortality, as well as infant mortality.
We've been
Okay.
focused very heavily on trying to bring everyone together on a set of shared goals.
Yeah.
So we've had a
Mhm.
nice convening. We've worked with the Hospital Association, now
Yes.
Primary Care Association,
Right.
trying to bring everybody to the table so that we're not doing a bunch of disparate
Mhm.
programs, but having a clear set, which I think we're getting
Yeah.
closer to.
Yeah.
Hey, I'm all about not having duplicative
Yes.
task, well, you know how I feel about task
Me too.
force and working groups. Now, it was required by the federal government. Are they funding this too? Do they provide some money?
They
For the-
did provide funding, but
Mhm.
I don't want to say that this task force is completely dependent on the federal grant.
Okay, that's what I want to make
Yeah.
sure that,
No.
given the uncertainty.
Yeah, no,
We're able to continue this work with,
absolutely.
I
beyond
think
that.
all the partners are enthusiastic
Yes.
about coming together and having some shared goals. It's the same people over and
Yeah.
over who are the primaries in a
Mhm.
lot of these things. So
Mhm.
everyone's been pretty responsive to that idea.
Yes.
Okay, with regard to home visiting, I understand that DC Health has notified Mary Center that the agency will be splitting the RFA for the federally funded home visiting program for the first time this summer. So more than one grantee will receive funding. Are we increasing the overall funding amount available, or is the funding that had been going to one grantee now just going to be split amongst multiple groups?
We received an enhancement too, but we will be splitting up some of the funding. We are trying to implement some more innovative models in the home visiting space and also taking on some aspects in-house. So one of the things we observed was that a lot of families were receiving what they needed, let's say within the first year of being involved with one of the programs. And so they left, and it wasn't considered a negative, right? That they decided that they got what they need, right? But
Yeah.
it wasn't necessarily meeting the requirements of the model of the program that they were within. So we're now trying to implement more of a lower touch, high reach program model as well. So that we can reach more families and also make sure that we're meeting the needs that they actually have and not just requiring them to stay in a program for 5 years if they don't really need the services after a year or two.
Okay. Have you guys had a conversation with Department of Healthcare Finance about home visiting?
Yes, yes.
Okay. I'm trying to understand the silos here because the council also funded a home visiting program through Department of Healthcare Finance for us to submit an application for home visiting services to be a part of the Medicaid program
And that
They-
was for nurse-family partnership?
for nurse family
Yeah,
partnership.
Yeah, that's just one of the models.
But it just seems a little strange to me that we have like, you guys have a home visiting program, they have a home visiting program. I recognize different models, but I do feel like we perhaps can get better bang for our buck, maybe.
Yeah, we can explore further, but
Okay.
yeah. But there are definitely different, families have different needs and the models are meant to be responsive to the different needs of families, whether.
For sure.
Yeah.
I'm gonna say it for the record, this is less for y'all and more for the EOM folks who are watching. We, $1.4 million we did for home visiting. Home Healthcare Finance has not spent any of that money because they refused to submit the SPA over a word. Again, that was less for you and more for them. Okay, I am going to switch topics. Oh, okay. We're going to talk some data. Center for Planning, Policy, and Evaluation.
Okay.
Okay.
Hello, Liam.
I want to ask some questions about dashboards and overall reporting. So in the responses, CPPE reports that the agency will be publishing several dashboards related to perinatal and infant health in Q2 of FY 2025. That includes a PRAMS data dashboard, a natality report, and reported pregnancies and pregnancy rates in the district from 2019 to 2023. I'm glad to see that this is going to include more recent 2022, 2023 data, because I feel like we've been stuck in 2020 data for a very long time. What are the sources of this data? And how will DC Health be able to report it more quickly than current reporting? Because if we're going to put the dashboard up and then it doesn't get updated, then yeah. If you could just introduce yourself for the record.
Sure. My name is Brittany Software-Callaway, and I'm the Senior Deputy Director for the Center for Policy Planning and Evaluation. And the data sources broadly come from our vital records data, so birth data, unfortunately, death data. And part of the lag that happens with reporting that information is that the data has to get certified federally before we can report out the information. I'm pleased to report that our most recent reports should be routed to Dr. Bennett by the end of this week, which means that they will actually make it out by the end of Q2.
Will they?
Yes, they will, 'cause I am not that slow.
No, I didn't know if it needs to go to you and then over here to 6 different people and
Well,
just saying.
there is a little bit more.
It's okay.
But in the effort to get data out a lot more quickly, we are revamping a lot of our data reporting processes to build more standardized templates that'll help the data be able to be processed a little faster. And then we're also transitioning to more of a dashboard model, which again will allow us to be able to push data out into users' hands a lot sooner. We're revamping the data that we're releasing so that it's less dense. There's not as much information there. That information is still available, but we really want to hone in on what are the most important things that the public is looking for so that we can make sure that that information is available first.
That's great. I like the report. I read y'all's reports. Whoever I read them. They have nice pictures and cute little glossy print, but sometimes you're just looking for a number,
Yeah.
and so we may not need the additional context piece.
People
So-
use data differently than they used to, where it was a little bit to be sitting on a shelf to be referenced. People have a little bit more directed
right.
interest, so we're going to match that.
Yes. So in the shift that you all are making, though, will you continue to produce current reports like the perinatal health and infant mortality report?
Yes,
Yes.
so those reports will still be produced.
Okay. All right. So the last version of that report came out in January 2023, and it only reported on data from 2019 to 2020.
Mhm.
When shall we expect an updated report?
That's part of the package going out.
Oh, that's part of the,
So
Okay.
we're going to get through 2022.
okay.
2023s will arrive about the same time. So we won't have to wait quite so long, and we'll be able to push them out on a more regular basis. There will always be that gap, partly because there's a long lag to be sure that the data is accurate. And then you've got the federal trying to certify across the country lag as well. So the data will come out, but it will not be like monthly data because the process doesn't allow for that. The data that does allow for that are things like what we do internally, our analysis of the data we get from investigations or other things. So there are data that can come out swiftly. The mortality data and birth data are very particular ones that the federal government has an interest in, and that they have more meaning than just how do we want to evaluate our own work. So
Yeah.
they are a little slower.
Look,
Anything we can
I
speed
hear
up,
you
we-
guys on that. I think in our new context,
Mhm.
the relevance of state and local public health agencies also pushing out very important data and communication is also going to be very important because we don't know if that will continue
Yes.
on the federal side. And
Faster.
frankly, whenever this is over, and I'm sure it will be over, hopefully someday in the future, we don't want 4 years of gaps.
Right. So we do have the data and we do own it.
Yeah.
We have agreements as part of the national system, but it's not as if we don't have it.
Okay.
So it is our data.
Good. I want to ask some questions about Vital Records. So I was happy to see that Vital Records has made some serious strides in improving its processing times
Yes.
since October 2024. So a 10% decrease in processing for mail issuances, a 19% decrease for in-person issuances. And I recognize that you all had to move
Yes.
in the middle of this.
Some bumps.
But what changes have you all implemented in terms of Vital Records? 'Cause I don't believe you hired more people in terms of processing. So
I don't actually think you need FTEs for all improvements. See, you're going to see some improvements that do not involve more people. But I'm going to let Dr. Sophia Callaway describe it because I think that team has worked really hard. One of the principles I think we're trying to see across the department is how do we improve the processing and moving through of requests that the public has and deal with unusual situations. They see an enormous number of people. So if you're going to do tens of thousands of something, not very many of them have to be different or weird or unusual or hard for there to be a lot of people who didn't get what they wanted. And that is what happens across the department. 98% of the work goes smoothly and is fine. But if it's 2% of 45,000, that's a lot of people.
Yeah.
And that has happened again and again. So I want to acknowledge that the 98, that always works out really well. And we are really working hard to make sure that we can give the attention to those 2%, 3% that need that extra attention because it makes everything else slow down. And so they've done some work on both sides of that, the regular processing time for everybody and how do we find the people who aren't getting what they want and help them sooner.
So I think central to that is we relaunched a customer survey. And through that customer survey, there's a QR code both in the customer service suite and a link sent to people that order online. We're able to collect data that informs the additional changes that we need to make. So through FY24 and the beginning of FY25, there was a lot of changes made to the customer service center, including the transition of promotion of 2 staff to create additional levels of management so that our customer service center can have a more efficient escalation structure. When we do have customers that need some additional assistance or that require some additional time, now there's a supervisor on the floor all the time who is able to help manage that situation a little more efficiently. We've also increased our signage, increased language access, including phone drops at all of the customer service stations so that people who need access to services in a different language will have that more readily. We're in the process now of upgrading our kiosks that are used in the customer service center. Those should be delivered within the next few months. That will allow for even more improved customer service experience and language access. And then all of our customer service staff in the Vital Records Center went through a intensive customer service training and language access training in the fall that we're planning to do a refresher of this spring into summer.
Thank you. I'm happy to hear that all of those changes were implemented, particularly I want to thank you all for how you responded to some of the cases that came to our office on language access pieces. And so it's good to hear that you now have those lines at every station, so you don't have to go into a separate conference room to have those conversations. So this is good. Frankly, I think most people, when they're interacting with DC Health, it's usually through Vital Records, or I feel like the Vital Records office is probably the most public facing in terms of people coming in each and every day to get something. And so kudos to that team for the work that you guys have been doing. Okay, in that regard still, there were 0 fetal death certificates or commemorative stillbirth certificates issued in FY24 and 2025. You know, unfortunately, we do have these tragedies that occur in the district. It makes me wonder why no families are using these services or do not necessarily seek out these documents. And that's nothing on you guys. I'm just curious. Is it perhaps that folks don't know that this is available to them?
So there isn't a requirement for the document in their life, right? So they don't need it to do anything.
Yeah.
And I'd say the vast majority of people who do vital records do it because some outside force is forcing them to show up with documentation, and that the births and deaths in their lives are experienced through a different lens than official pieces of paper until someone makes you do that. So it may just be that people have not felt the need, but we do make it available, and we do let all of the healthcare providers that are relevant know about it. So it is not something that we don't continually push out.
Okay.
The same with out of institution births. That information gets pushed out, and we get information back from people to the degree that they need it, I think.
Okay. In that, well, sort of still vital records, a little bit different. We had a conversation with you all last year around the protocols for reporting an at-home birth.
Uh-huh.
And especially if there is no witness, but otherwise just allowing, we had discussed you all putting the information on your website. I don't know, I'm not gonna call it a checklist per se, but like, before you come, here's the information that you need, and this is what we're gonna need in order for
Yes.
you to essentially prove that the child was born here in the district. Have those processes improved in terms of, individuals who are coming in seeking birth certificates for at-home births?
Yes, the information has been made available on the website. What I will say is in FY25, we are seeing a slightly longer processing time for those, but it's because the cases that are coming in require a little bit more attention, and so it takes a little bit longer. One of the things that we're planning for later on this year, though, is to do a more concerted engagement with our colleagues in CHA to make sure that information is available for doulas and midwives and some of the other teams, so that that information is readily available and in the hands of people when they need it.
Okay, thank you. When we have to have these conversations with folks and just kind of explain like, no, you can't just present a baby at DC Health and we give you a birth certificate.
Yeah.
Like, I kind of need to know where the kid.
It's an incredibly powerful document. We make citizens. So that is a thing that we, the public, the government, the federal government, have an interest in being really, really clear about when we do that. And so it does take documentation. But the kinds of documentation are really broad. So we will let you use a metro ticket with a timing on it to show you were in DC. We'll let you use a lot of things. So many, many options are there. But if you did not go into it having looked that up first,
That's what I'm saying.
you
Like,
may not have saved it. So we are going to really push out to hopefully, the birthing community to see if we can pass that along. Not everyone makes contact with that community. I mean, if you really do take this as a personal journey and don't contact anyone, then I think it gets very difficult. But I think we have limitations in what we can do for folks.
okay, all right. I want to talk about SHPTA. See you in. Thank you to the team. Okay, so got 5 hospitals who have not met the required level of uncompensated care for FY 2024. Several of these have not met the requirement for 3 or more years. Now, at last year's performance oversight hearing, you all testified that when a hospital does not meet its uncompensated care requirement, SHPTA requires them to submit a corrections report. How many of these hospitals have actually submitted that document?
So my name's Terry Thompson. I'm the director for the State Health Planning and Development Agency. So I know of 2 that have submitted reports to bring themselves to compliance. And we're working with others to make sure that they, as well as the other communities, to make sure that they're in compliance.
Okay. Beyond the submission of the corrections report, what other enforcement actions does SHPTA take if a hospital does not meet its required levels?
So we're authorized to do civil enforcement. So there are fines that could be assessed.
Okay.
We are, for obvious reasons, resistant to enforcing through fines with individuals that are trying to work with us to come into compliance.
Okay. Frankly, some of the hospitals, I was a little surprised that they haven't met it yet, given where they're operating. And not all of them. Some of them, I'm like, oh, okay, that makes sense. But for some of them, I'm like, you're in a central part of the city. You're right next to a metro. It just,
It's necessarily mean they haven't delivered that care. Oh, sorry. It doesn't necessarily mean they haven't delivered that care. They haven't delivered the documentation to us to show that they delivered that care.
Okay.
Which does require some accounting and a little math. And so it is not it's not a entirely straightforward process, meaning they probably don't have that report. They need to produce something, and that is what they're failing to do.
Okay. The State Health Coordinating Council, which advises SHPTA on CON and the state health plan, has 15 seats. It also has 10 vacancies. So
So
what conversations are we having?
we have been working with MODA. So as you've noted, we've actually replaced 4 of our members. We are aware that there are other potential candidates that should be coming out of the mayor's office.
Okay,
So they're under review right now, and then the documentation will flow your way.
okay. Of the seated members, have you all been able to reach quorum for meetings?
So we do meet a quorum requirements. So it's 50% plus 1, and we don't.
Oh, 50% plus 1 of those who have been named?
Of those who are present. SHPTA operates. So SHPTA, the SHIC has its own statute,
Yes.
which is separate from the mayor's statute.
Okay,
And so its bylaws allow for a quorum to be met with 50% plus 1
of the
sitting members.
sitting members?
Right, not of the membership.
Okay, that's the clarification that I thought you were saying 50% of those who
I'm
were
sorry.
present. And I was like, wait, that doesn't.
We have great attendance.
Yeah, okay. Okay. Do you think that the size of the SHIC should be reduced? Like, is 15 too many?
So 15 is difficult to fill. And once you lose members in groups, then it's hard to keep up with. So from that perspective, it does create a membership that, reaches a broad swath of the city. There are 2 members that are not designated, so there are 13 designated members. The
Okay.
number 15 stayed, although 2 members were repealed.
Has the SHIC ever had all 15?
In my lifetime, it has, but it's been an awful long time.
In your lifetime? You were, it's like Terry was born with the SHIC. I mean, like, come on. In my lifetime, yes. Bad. Okay. Okay. All right, well, we'll continue to try to work with MODA. I think we did just do a couple of these nominations to at least get it up to the 5. And so 15 is a lot.
I'm
It
a
is a
fan
lot.
of any group having a nimble number of people that can have an actual involved conversation.
I feel like 9 is
Having
solid.
anything more than, I would say 10, less than 10 is always
9.
an ideal. So anytime we can have a conversation about how to make a group more efficient and effective, I'm open. Let's have it.
Okay, all right. So in FY 2023, there were 38 letters of intent for CONs. You all issued 24 CONs, but in FY 2024, though you did still have 38 letters of intent, only 9 CONs were actually issued. What do we say for the cause of, I would say that's a dramatic decrease from 24 to 9. Were more applications rejected, or did more organizations just choose not to go forward?
So we have letters of intent that are still pending. I believe they're awaiting.
Oh, from FY 24.
Correct.
Okay. Did you guys reject more in
No,
FY
so
24?
we don't reject letters of intent. So if someone
Well,
submits.
no, applications, I mean.
No,
Okay. All right. In FY 2024, it took on average about 73 days to complete for a CON application, the longest taking 94 days. Do you all use business days or calendar days in your counting?
we use calendar days in our count.
Okay. Has SHPTA ever considered doing expedited 30-day application timelines
So
for priority projects?
there is authority for us to do expedited reviews, and we do that when there's cause to. There haven't been many that have been done since I've been the director.
Okay. All right.
So I will say that generally the time is about the applicant submitting information to the SHPTA, not the SHPTA's review of the application.
Okay. When it comes to corporate acquisitions or consolidations of healthcare entities, which is now happening more often, we're starting to see, how does SHPTA determine whether a CON can be issued?
So the SHPTA reviews the documentation and makes sure that, so the statute has a list of qualifications or requirements, and they have to meet each of those requirements. Presuming all of those are met, then the
Okay.
application's approved.
Do you all work at all with the Office of the Attorney General on monitoring consolidations?
We do, and we get calls from them often.
Oh, okay. Glad everybody's working together on some of those. Okay.
I will just say the role that corporate investors have in the healthcare field is one that is a growing issue across states. So I've been in conversation with Pennsylvania and New Jersey and others, and still about to be in conversation with Maryland and Virginia to really try to figure out what the policy response to it is, because a lot of what we've written in the past didn't really envision what it is that's happening now. Some states have seen really aggressive entry with closures and other things happening. We have not seen that, but we are trying to prepare to be as forward-thinking and aware of the problem as we can be, to be prepared and maybe even proactive.
Okay. If we feel at some point that our existing statute is not keeping up, then we need to sort of address. And it's interesting, we're having these conversations, but most of the public doesn't know who owns their
Right.
practice, right? And then as a result, then who owns their data, and what happens with that information, et cetera. There's been some quiet nationwide reporting about it in terms of like the number of VCs who are entering
Yes.
into this space, which makes me very nervous.
Especially long-term care and smaller hospitals have been, other states have had a much harder time, but that does mean that there is model legislation and approaches that have worked and not worked that we can learn from, which is what we're trying to do.
Okay. All right. I don't have any other questions on SHPTA. We had a whole hearing, so those are the joys of the hearing process. I want to switch to HOSTA. I have to give kudos. The district met an incredibly important milestone, which is less than 200 new HIV diagnoses for the first time since the 1990s. So, yes. Now, unfortunately, means we losing our money because we
It
did
does.
well,
We did too good of a job.
which is so backwards in some ways. Like we gotta keep spending in order to maintain such good progress, but this is huge.
There are other cities that have seen really significant increases. So we are in a very good place.
Yeah.
So I don't want them to take our money, but I'd also rather not be any of those places.
Well, how much money did we lose in FY
A
20?
lot.
Yeah, we lost almost $4 million
Yeah.
in HIV prevention.
You said 4 million?
Yes,
Oh,
40%.
okay. 4 million. Are we expecting to get cut even further?
That is a possibility.
That's a possibility. Okay. But I don't know. I know y'all don't have a crystal ball, but I got to ask the question that we kind of need to think about here. Okay. Do you believe that we'll be able to continue making progress to meet our ending HIV epidemic goals with this decreased level of funding?
Okay, I didn't introduce myself, so
Oh,
let me do that.
I'm sorry.
I'm
Yeah.
Clover Barnes. I'm the Senior Deputy Director of HOSTA. And we are working really hard to maintain the community partners that we have and the programming that got us to these milestones. it will be a challenge for some of our organizations to continue to provide the same capacity and level of service with decreased funding.
Okay. Now, we did lose some money on the federal side, but there were some significant lapses for the reducing new HIV incidences federal grant, about 4.3 million in FY 2024. In the explanation, HOSTA reports that funders were not available for HOSTA. Repeated attempts to encumber funds failed. Can you elaborate on this a little bit?
Yeah, the grant went from 2020 back, and I think there was I'll call it a discrepancy in accounting.
Okay.
From the funds from back with the change of fiscal systems and back to the previous when it first started, that we tried to encumber the funds but weren't able to when the funding was available.
Okay. All right. So the council funded to restart the sexual health peer-to-peer educator pilot program. It's intended to be implemented in schools. My understanding is that the grantee selected by DC Health has no peers working in schools. So what are they using the money for?
The grant was just awarded in January.
Okay.
And so they are working to build up the model now.
Okay. All right. We will then check in on that. The council also restored about 300 Okay, sorry, hold on one second. Okay, so we provided 350,000 for the Get Check DC program for the self-testing kits. A portion of that got reprogrammed. Now, so there's a remaining 210,000 that's being used for a new model that relies on community organizations to distribute the kits. Have you all picked the organizations that you're going to be partnering with? And do we anticipate being able to get out the same amount of kits with this type of model?
So with the funding cuts that we experienced from the federal funding, it changed our staffing. And so we pivoted to a model where our funded prevention providers, who we know do outreach at large-scale community events, as well as outreach to places where people are at highest risk for HIV, have a cadre of kits that they give to clients that they see or people that they interact with at the outreach events to get them out into the community. They also have programs where people can request them from their agencies. So they were already contracted. It wasn't a point of us creating new contracts for this.
Okay.
We also are working to reestablish it in the way that it was, using some different mechanisms, some automations that verify mailing addresses, because we got a lot that were returned, so that we can establish a different portion that's more efficient than what we were running in the past. But we do still have kits going out in great amounts. We have providers, we make them certified that they're going to submit the results of how many they gave out, if the clients report results back to them, et cetera.
Okay.
And so there's a little process they have to go through. But of our 10 funded prevention providers, 6 are currently giving out self-test kits.
Great. The committee was very impressed when we visited the Health and Wellness Center this summer. And in the responses, DC Health reported that the center started providing the long-active injective PrEP to patients in May of 2023, and that this form of administration for PrEP has been incredibly popular. I'd imagine because it's long-acting, and so as opposed to having to take the pill every day. Are there challenges to prescribing it to more eligible individuals?
There are, depending on their payer, their prior authorizations, and
prior
those
auth.
kinds of things that happen. Thankfully, not with Medicaid, but sometimes we have people who have private funding that come. Some people who may not have coverage, and we use a patient assistance program before we go to our PrEP DAP to try to get it covered most efficiently. And so those all take time and some legwork by the team. We have a PrEP navigator who works through those issues and submits all those prior authorizations for the clients.
Okay. I'm glad that prior auth is not a problem on the Medicaid side of things. Obviously, with the private payers, that's a little bit different, but I'm just like, if this works better to ensure that people are protected because they don't have to be like continuously do this thing, why make people jump through hoops? But that's a larger philosophical question for the pharmaceutical industry as well as the health insurers. Okay. So one of the things when we also hear from folks in the community about the wellness center is that its impact is limited because there are no evening or weekend hours. The staff there are fantastic.
They are.
Like, what level of funding would it take in order to expand hours there? And I'm not talking stay open till midnight, but I am, 6 o'clock, 6:30, or even have a time slot available on Saturdays.
Mhm. We could get you some numbers
Okay.
for how much that would cost.
I think this is going to be incredibly important even for World Pride. Like, I don't even know if it's got to be temporary, but we got to figure this out to maybe it's, a 1 month stretch where we expand the hours. But I think that, that could be super helpful. Now the staff is great, but the center also doesn't have any counselors or social workers on staff, even though, a patient might receive a life-changing diagnosis right there. Have you all talked about perhaps adding that as a component?
We would love to have a social worker on staff or a counselor. We haven't been able to afford that. Our nurses, though, are very skilled in delivering, hard news to people and supporting them through that process. We also have peers who may be in the clinic at different times who can support. We hire staff who are living with a lot of the conditions or have experienced the things that they are diagnosed with, who can give support in a different way as well.
Okay. For follow-up, I would love to know how much money we're talking about here to expand the hours, not dramatically, but enough to be effective. Adding time on Saturday, on the weekends, I think could also be something as well. In that regard, and like I said, we might need to just temporarily do this for World Pride, but how is DC Health part of the World Pride planning conversations? Whether it be, when I see the projections of how many additional people, right?
Mhm.
Forget, the other stuff, right? Hospital room,
Yes.
folks come here, they're gonna do crazy
So
stuff.
there are two levels. There's the level that we do with any large event, which is work with our Health and Medical Coalition, work with HCMA to make sure that we're prepared for the eventualities that happen. Do we have medical care availability? Are we expecting people to be congregated in an area or another area that we need to be clear about? Are there food sellers? So we are doing that part.
Okay.
This is an event that HCMA is preparing for, that we're preparing for. So that part is happening. The other side is with us as a care provider and health education provider, and we are also doing that. I'm gonna let Clover talk about
Yep,
that
so
part.
we participate in World Pride planning right now with the Mayor's Office of LGBTQ Affairs. We are working with partners. I'm actually meeting next week with the state AIDS directors for Maryland and Virginia about how they can lend some support as well to try to figure out how we can provide. We typically stand up a wellness pavilion and provide some like DoxyPep and PrEP and condoms and HIV tests, all those fun things. And so we're looking at how we can do that with partnership from other community partners to stand something up so that we have a presence throughout the Pride activities that are coming up.
I'm glad to hear of us sort of trying to approach this from a regional standpoint because, Northern
People will stay
Virginia,
everywhere.
they stay everywhere they are. But really, this is something a large moment for our region.
Mm.
DC may be the host, but you know, I like to think of us as a tri-state area. And so on this, I think we need to work together. And to the extent that the public health agencies from these other jurisdictions can be helpful, I think that's very good. One last question here, and then let's take a break because we've been sitting for a minute. So the Child Behavioral Health Services Dashboard Amendment Act of 2024 was passed. Part of that does require some coordination with DC Health, because my understanding is that this dashboard is going to be housed on the Link U platform. Yes, I know. We do try to separate them out so we get the same person. So I'm curious in terms of what initial conversations you all are having around the implementation of this.
Well, everyone is excited by Link U. We started using it and apparently we've become quite popular. So we've had lots of conversations. with
Yeah,
people
so we're
about this.
working through with the vendor who runs Link U for us on how, like, the changes that we want to make, how we make those, what they look like, what we'll have to pay for, you know, specifically, and what they have already included. So those negotiations are going on right now.
Okay, so those conversations have started.
Mhm.
Fabulous. Okay, let's take a 5-minute break. And then just telegraphing where we're gonna go so people don't go home. We're gonna start with the Health Systems and Preparedness Administration, which I think is new-ish for the reorg. So we're gonna talk licensing, we're gonna talk long-term care. And then, you know, food inspections, animal control, et cetera. Go forth. Be back in 5 minutes. Okay, and we're back. All right, I want to ask some questions about emergency and trauma response and reporting. I first want to congratulate you guys on the establishment of the new administration. Reorgs are never easy, but sometimes they're necessary just to make things work more streamlined and efficient. I want to follow up on something you mentioned in your testimony, Dr. Bennett, about the joint project between DC Health and FEMS and the Hospital Association to decrease the ambulance wait offload times by
Yep.
35%, down to 1 hour and 7 minutes. What strategies did you all employ to actually decrease those timelines?
So I'm going to let Sam Hurley discuss that, who's my senior deputy director in that area. But before that, I want to give you just a little context. So we don't have authority to tell the hospitals how to run, except in a limited area that's really related to patient safety most of the time. In this case, there are a lot of factors that go into when the ambulance arrives, how long the patient takes to go off. Some of it's about staffing, some of it's about how busy the ER is, some of it's about how severe or not severe, more likely the patient is, and how urgently it needs to happen. So there is a perspective the hospitals have. There's also a very valid perspective we as the public have in having ambulances be available. And so both are really important and valid and had to be taken into account, which is why this is something that we are acting as convener and mediator and data source of truth for really the two active sides of that equation, which is FEMS, Fire and EMS, and the Hospital Association, so that we can have a conversation. They had already been talking, but not necessarily productively, because it is hard when you have your interest and they have their interests to really meet in the middle. I think the data has been an incredibly important place to meet. We were not even all using the same definition of offload or what time frames we were talking about. So you had competing views of reality for the same set of facts. And so getting everybody on the same page and getting a single source of truth and being a little bit of a neutral mediator is a role I hope we can play in lots of areas. But in this one, I think it was really important for an ongoing conversation that had not been moving otherwise. So what strategies have we used?
Yes,
If you could just introduce yourself for the record.
absolutely. So my name is Sam Hurley. I'm the Senior Deputy Director for the Health Systems and Preparedness Administration at DC Health. And we are excited for the impact that we are seeing from the program that we have related to reducing ambulance patient offload times, or APOT times. As Dr. Bennett alluded to, one of the first things was to level set and understand what are we measuring, because I will tell you that there were different measurements based on who you were asking. If you were asking DC Fire and EMS, they were looking at one time set. If you were asking DC Hospital Association and the hospitals, they were looking at a different set of times. And the problem is that when you're talking about comparing them and how successful is said intervention, it's really hard to determine that. And there is a lot of, for no better word, finger pointing of, oh, this is the cause of that issue when the times are not standardized. So now that we have standardized the times, we started sharing information and data. Data visibility was super important for the hospitals to actually make meaningful change. So each hospital and emergency department is different, right? So, you know, the structure and layout of Sibley is much different than the structure and layout of MedStar Washington Hospital Center. And they have quality improvement staff that work for their healthcare facility that can go through quality improvement plans within their facility to ease the flow and stream of patients. So we really want to empower the healthcare system to be responsive, but then have that collective accountability and bringing people back to the table. So we had we started out with bi-weekly meetings, so every other week. Now we're down to monthly meetings. We set goals and performance metrics of where we wanted to go. And we published dashboards and reports weekly that go to every healthcare facility in the district so that they can see themselves versus the district as a whole, so they can compare themselves. And then they can see collectively the hospitals to compare themselves among the hospitals. So they see each other's overall data so that they know, oh, I am the outlier. I am the problem. They can see that and identify that for themselves to understand where they fall in that space. In addition, we have also encouraged hospitals to put in more information within their hospital. So Howard is leading a pilot project where they actually have a signage, live signage within their emergency department that says how long that ambulance has been waiting to help reduce those times. So those are things we are actively doing. I will tell you, in 2003 January, this is something we didn't tell you, it was 2 hours, the wait time. So we are down from
Oh,
2
wow.
hours from 2023 to 1 hour and 7 minutes in 2024 or 2025. So we have made big strides in the past 2 years, but we have really been working on this actively over the past fiscal year.
What is the biggest challenge to decreasing this time? I'd imagine it's staffing capacity, X and X and X.
So there are a myriad of challenges that are associated with this. I think we can point to staffing, we can point to some of those things. I would argue that some of those are superficial. Part of this problem is system coordination and moving patients throughout the system. So the ED is not necessarily, it's not the problem in the ED, it's moving the patient to the floor, but it's making sure there's a bed on the floor by moving that patient to a facility, an outpatient facility. It's that facility moving the patient, discharging the patient, or having availability, or there being respite bed capacity, a safe place to discharge people to. So it's system coordination. We may see that, yes, we can make incremental changes with staffing and improve throughput, but overall, it's making sure that there's greater system-wide coordination. That's how you get to the root of this problem versus just those incremental changes. Yeah.
Part of the reason we didn't prescribe, you all need to do X, Y, Z, is because it's a complex dynamic system. So there's the judgment of the individual nurse who's on at that point. There's the process you do for triage, which may only happen in that room and they do it mobily, or every hospital runs slightly differently. And so there are lots of reasons, and I'm not entirely sure what the reason is at any one place until they do that analysis, which they've now done. The system flow issue that we're talking about is why we put all of the healthcare systems together and took out the environmental health parts from that remit so that somebody could be looking at just how the health system functions.
Yeah.
And we do know that we have problems in one area that roll back to another. So if you cannot find a behavioral health provider or something for a patient and they end up in the ER, then that's a bed in the ER, that's a particular amount of staff time. How does that impact the availability of a nurse to take that patient off of the ambulance? So all of those things feed into each other. And so what we're trying to do is take a systemic look and look at, if you are trying to follow folks through the system, where are we getting stuck? Where do we have a deficiency in enough capacity so that people can get what they need when they need it, and you don't get backups like this?
Okay. In sort of the changing a little bit to sort of mass trauma, you never want to have to need it, but DC Health did update the mass trauma plan in FY24, including a 3-stage plan for when the district needs to ask for support from regional and federal partners. Have we had a stage 2 or stage 3 type of event in the past few years where we needed to request additional support?
January 19th, or no, was it, what day was it? When we pulled in, we called for the plane crash, pardon me, 26th.
Oh, I see.
Yes,
Okay.
sorry, got the
Okay.
date wrong. But yes, we did pull in, so we requested from both Maryland and Virginia a myriad of resources that began converging on the district in the case that there were survivors. So there were helicopters flying towards the district from Maryland that night at around 9 p.m.
I see. Okay. All right. Were there any other significant changes that DC Health made to the plan?
Majority of the plan updates were around just changes to systems. So we went from the health information system, what we called HIS, to EM resource, which is just our data sharing system. Same capacity, just name changes, and how that's accessed and used. But functionally, it's pretty much the same plan with the same partners.
Okay. I'm pleased to hear that DC Health is making some significant progress to improve trauma data surveillance by merging EMS Trauma Center and MPD data to develop a post-crash care dashboard. Are we still on track to publish that at the end of FY 2025?
So yes, ma'am, we are working to integrate data sets with EMS data and MPD data will be the first data set that's integrated. And that will be available hopefully within the next few months. We are still working on the data sharing agreement with MPD.
Okay.
But we have the agreement from MPD to do it. We are just going through the data use agreement process, lawyer's process.
How will the data for this dashboard differ from Vision Zero data?
So this dashboard is going to actually link the clinical information to the law enforcement information, which, for instance, that could give you insight in are majority of the wrecks occurring in a certain vehicle make or model? Are they occurring with what roadway conditions? Because in the patient care report for EMS, they don't document whether it was raining. Instead, but in the police report, using MUC criteria, they do. So we can start adding these factors and layers of information to better understand when we are having traumatic injuries and the actual severity of injuries, because law enforcement are doing, they're assessing severity based on a small nominal scale of, not severe, severe, likely fatal, fatal. And so, but that's based off a law enforcement officer and their impression of the patient. Most law enforcement officers don't have a clinical background. Now I can actually add a blood pressure, vital signs, other physiological measures to actually say, is this a likely fatal incident? And what are the other factors co-occurring with this? The next stage, what we are also working on, is adding on the trauma registry data to that data set. So EMS, MPD, and trauma registry data. So now you have the hospital data, and now you know for a 30-day window following an incident, did they die? What happened? Were they discharged? And what kind of adverse or positive outcomes do they have in their clinical care? So it paints the full picture of traumatic injuries in the District of Columbia.
Okay. The council funded an additional FTE to hire a data analyst to bolster the agency's research on traffic-related injuries. Has this position been filled?
So that funding came available in October. We didn't have that position at all, so we had to create a new PD for it. We are starting recruitment hopefully by the end of next week for that position, because we have finally gotten our PD approved and all of those good things.
Okay. DC Health provided screenshots of the new dashboard, which shows that for 71% of post-crash fatalities, DC Health is unable to determine whether the victim was the driver, the cyclist, or the pedestrian. Is this just because this is new, or the reports were just unclear?
So it's probably a combination of both, candidly. But that's part of the idea of linking these data sets together, is we start identifying opportunities for improving the data sets for all components. So DC Health is an active participant in the Traffic Records Coordinating Council here in the District of Columbia, the TRCC. And that is where we can bring those lessons learned from our data sets to say, hey, this is an opportunity for improvement where we need to know whether or not they're the driver or the passenger or what position they sit in the vehicle. Because based off MUC criteria, which is the model uniform or criteria for law enforcement reporting for crashes, there are guidelines and standards of how that's reported, but that's something that we can provide that feedback. And it may be something that we as data scientists less familiar with their data may ask, hey, is this something that you can tell us where to find it? Because it may not be as clear for us. So it's that feedback mechanism. We're still entering this foray, and so it's a work in progress.
Okay. In your pre-hearing responses, DC Health reported a $2 million spending pressure for the software licenses for the DC Health disease surveillance systems. I understand that we had paid for this, I guess, with COVID funding. How was the system funded before COVID?
We used different systems before COVID. Part
Okay.
of what happened during COVID was the pressure of an incredibly large amount of data that we had not previously had to deal with meant that new systems were built. And so some of those systems are maybe not optimized what we need them to be now. So now that that isn't the kind of data that we're exclusively using. So we're looking at all of the data systems and what do we actually need to go forward with and right sizing them all. But that is why that was created.
Okay. HISPA reports that it will lose 6 FTEs in June 2025 due to the sunsetting of 2 one-time federal grants, the Public Health Emergency Response Grant, Public Health Emergency is over, and the MRC Strong Grant. I'm less familiar with that one. What did folks under that grant do?
Yeah, so the Medical Reserve Corps, or MRC Strong Grant, is a federal grant that's a competitive award. And so there's a limited number of opportunities. It isn't a cooperative agreement, so every state isn't guaranteed funding. We just received an award 1 year, for the 3-year performance period. And that is coming to a close. During the performance period, they were doing trainings and recruitments of Medical Reserve Corps volunteers in the District of Columbia to increase our cadre of staff or volunteers who are participating in the program. And those trainings included Stop the Bleed. So how do we educate members of our community about bleeding control and those types of things, being that type of behavior and that education actually saves lives when you think of mass trauma and those types of events. There also is CPR training, so we partner with DC Fire to help coordinate CPR training. Additionally, we are funding the acquisition of Stop the Bleed kits, so putting tourniquets in locations throughout the district so that in the event of a tragic incident, whether that be a shooting or a vehicle ramming or someone just having a bleeding incident, that there are in the area tourniquets that are available. And then those will be supplied to the E911 system at OUC so that they will have visibility of where those resources are so that they can inform bystanders on the scene. Hey, you're in front of 100 Main Street.
Mm-hmm.
There is a Stop the Bleed kit inside this facility.
That'd be
I
great.
just want to clarify, it's not always clear to everyone, but what we do when there is a large scale trauma or some need for additional medical personnel or even non-clinical personnel to help out, those are all volunteers. And so having a well-trained, well-connected set of volunteers means that when something happens, we will be able to call on doctors and nurses and other folks who are available that day who will then come. And so that is what that's about, trying to really build those connections so that we know we can count on those people.
Yeah. Okay. Well, Mr. Hurley, you're doing a great job. So thank you.
Thank you.
All right, we're going to switch to health professional licensing. What's that? Okay, so overall, DC Health has definitely made some big strides to fill the vacancies that have existed in some of our health licensing boards. But some of our boards have lagged behind. We heard testimony on Monday about the Board of Social Work, which only has 2 members currently, and that they've struggled to meet quorum even with those 2 people. I know that this is what do we call it? A joint collaboration and partnership between you all and MODA on sort of advancing some of this, but how has recruitment gone in terms of the Board of Social Work in particular? Because there are some things that we need them to talk, discuss, move on, and if one person doesn't show up, they can't act.
Hello, Aisha Nixon. Associate Director for the Office of Health Professional Licensing Boards. So recruitment and partnership with the Mayor's Office on Talents and Appointments has been going very well. All of the executive directors typically meet with the Associate Director at MOTA on a monthly basis, just to check bases. And we have a shared kind of spreadsheet regarding who's on any off-cycling as far as people whose terms are about to come to an end, if there's a need for a reappointment or if that person's going to expire out. With the Board of Social Work, actually, they have been one of our boards that have been fully staffed for the last 5 years. Unfortunately, during FY24, one board member stepped down, and then one of our board chair termed out. And so that pretty much led to them only having 2 board members. They've only had 1 meeting that they had to cancel due to a lack of quorum because it's only 2 of them. Both of them have to be present in order for them to have the meeting.
Yeah.
MOTA has forwarded resumes. So typically the partnership is that we will review the resumes of the professionals that they submit, kind of check our database to make sure that those individuals are in good standing with us and that there are no issues. And then we would have a joint interview, and from our perspective, we're not interviewing them. It's really an information session for us because we know that the mayor will make the determination on if they want to move forward with that person. But in that information session, we kind of provide in the interested parties kind of the scope of the work, the time obligation, because again, a lot of people want to be on the board, but not understanding the time it takes, the pre-work that is needed so that they are fully available and ready when we have the meetings to address concerns in open session and in closed session. So we do have a set of resumes that we will be reviewing to fill the seats for the professionals.
Okay, so there's the board and then there's the staff. When we look at, the average processing times for approval for applications, social workers is longer than any other profession at this point, which is interesting to me. 32 days for LICSW, 41 days for independent social worker, 28 days for graduate social workers. Is this related to board vacancies or is this something else?
No, actually, it's not related to the board vacancies.
Okay.
It is about the process. So with social work, a lot of our applicants are entering into the workforce, and DC is their first place of licensure. And they also have to then sit for their national exam. That being the case, they have 120 days. That is typically why you would see that someone's application takes a certain amount of time. So with certain professions like social work, we have to grant them permission to sit for the exam. So their application timeline starts the minute they submit it. But if we grant them permission, they
And then the date for the test is not for
and
another.
yes, and some of them may take the test right at the 120 mark, like that last month, and then that kind of is one of the reasons why it appears that their application is extended for so long. Of course, there is times when we do have to take things to the board if there is a positive criminal background check, if there's any issues as it relates to their education or their experience that they've garnered, because that's typically the other space is their
Supervision
supervised hours.
Yeah, okay. We did recently receive a complaint from the School Social Work Association of DC that the Board of Social Work has stopped accepting applications for CEUs and is referring applicants to national accrediting bodies which charge higher fees. Why have they stopped accepting applications for CEUs?
I'm not aware of that. I would have to get back. So the Board of Social Work does have the ability to review continuing education. We usually ask that individuals who are submitting continuing education review for classes that they want to host, that they do it at least 60 to 90 days in advance so that we have time to get it before the board in open session. But I'm not aware that we have stopped reviewing any continuing education.
Okay, can we follow up on that?
Will do.
And then it also came up at the hearing on Monday around the group supervision model to increase access to supervision for social work graduates. Is this going to be on the agenda for the next meeting since this meeting was canceled?
So it was the January meeting that was canceled.
Sorry.
They actually did meet on Monday
Oh.
when the hearing was going on. I know that it is something that they are looking at, and they do plan on revamping and revising what the group supervision looks like as far as the requirements, and that's things that we would have to update in the regulations.
Okay. I do want to applaud the team for decreasing license processing time overall from 30 days on average in FY 2023 to 19 days in FY 24. And in so far this year, it's just been 8 days. So kudos to the team because I know that you guys don't always control whether or not the applicants are submitting all of their appropriate documentation in time. But yay. Okay. I did hear, we have heard a concern from some licensees about the new system. In particular, it says, okay, depending on a person's birthday, they may have to renew their license only 13 months instead of 2 years after their last renewal. But DC Health has not indicated that their fee or CEU requirements will be adjusted accordingly. So my understanding is you guys are adjusting to a new timeline of, as opposed to everybody renewing on one particular day, you're not going to renew based on your birthday.
Yes.
But there's some people who are kind of caught in the shortness
So-
because of
They
that.
will, in this 1 year, they
Yes,
will.
they will. It will. So the term of licensure is what is being, what has been changed. So that will allow for there to be an even distribution of renewals so that we are not in a space where individuals are all renewing. So for example, we're coming to the end of our late renewal period for the Board of Medicine. That is 16,000 people all renewing at the same time. And that's just one board. We have several other boards that renew at the same time period. So not to overload the system, in working with stakeholders, the thought was that to move it to the birth month. That being said, there will be individuals that will have the license for a shorter period of time. It is the same thing that happens if a license was granted in the previous term of licensure. And when I say this, it's, for example, the physicians, their license all expired December 31st of every even year. In our system, we were not allowed, we don't have the authority to give them a license with a 2 years later until we wouldn't, if you were applying for license, like if you applied for a license and we would reach out to people in August and say, hey, do you want to wait till September 1st? Because if you wait till September 1st, you will get your license for 2 years. If we granted your license August 1st, you would have been renewing December 31st. What happens in that space is that you're considered a first-time renewal. You still pay the same fee as everyone else, but you were waived. We would waive the continuing education requirements because you would not have had the same amount of time to accomplish that.
Are we offering that
We are
waiving?
in conversation and working with legal because that will require a regulatory change so that we can do a waiver of the continuing education requirements, at least if not partial. The only ones that would be required are the council mandated continuing education requirements and our public health priorities.
Okay. As you all make decisions in terms of what you're going to do there, can you just communicate with the committee so as we can be consistent in our messaging with that part?
It'll be a painful year and then we'll be much better. Your chance of your slightly irregular application that had 1 or 2 bumps in it getting processed well and us getting back to you on time and telling you there was one small thing, let's fix it and get you going. It is very hard to do that when an individual is trying to do 2,000 of that thing for that month. So giving people the attention they need so that when there are problems, they can be fixed is going to be much, much easier after this one awkward year. So
Okay.
I'm hoping all my colleagues.
Transitions are hard. People
Yes,
don't
they
like
are.
change.
But the end
But I
will be
could also
better.
feel though, like if I have to meet the
Right.
CEU requirement in particular
And pay the fee again, as I did.
and pay the fee
Very
and I'm
shortly
not
after paying it
getting
the last time.
the full benefit
Yes.
that everybody else is getting.
And unfortunately, the time of licensure and the fee are both legislated so that we were unable to.
Oh, you guys can't just say.
Yeah, we can't just change.
We're
that.
gonna give you a
We tried.
prorated.
We would love to prorate. We were not able to do that.
Okay, all right. While we're still talking about boards, we've got 2 new boards that were established in the HORA. I gotta do better. We're not supposed to use just acronyms. Okay, Health Occupation Revision Amendment Act, also known as the HORA. They are scheduled to start operations 1 year after the effective date of the legislation, which would put them July 2025. Okay, we have not received any nominations for these boards yet. I just want some comfort that you all are having these proactive conversations with MODA of like, hey, the council goes on recess when the council goes on recess. And so then nobody can hold a hearing and no one can be approved in August. So we need these nominations ideally in May.
Yes, so we are having active conversations with MODA regarding the 2 newly established boards. One board is really a consolidation of
Yes.
3 existing boards, and so that is a little bit easier. More than likely, it will be some form of a reappointment or new appointment for existing members for the those boards that will sunset. The other board, which I know the name is potentially going to change, they will also have the opportunity for some of the existing members from the Board of Chiropractic to then be appointed to the new board. And then we are working with MODA. They have requested our data related to the 2 new professions
Okay.
for acupuncturists and naturopathic physicians.
Yep.
So that they can do recruitment. And we've been notifying our public or our licensees in our open session meetings, letting them know if you're interested in being on a board, what they need to do and who they need to contact.
Okay, we'll give our PSA now. So we have 2 boards. We're talking about the Board of Rehabilitative Therapy, 11 seats. God bless. And the Board of Acupuncture, Chiropractic, and Neuropractic Physicians, although we haven't officially voted on it yet, but we're gonna act like we did. We vote on it next week. 7 seats on that particular board. So if you are a professional who is watching and a board is an excellent way to serve your city as well as your fellow colleagues. Go to the Mayor's Office of Talent and Appointments if you are interested for more information. All right. Lots of interesting things happen on boards, including investigations of complaints. So there were 94 complaints made to the Board of Medicine in FY 2024, but only 24 investigations were initiated. We did ask for a breakout of the types of complaints, but the responses did not include that information. I mean, maybe you could tell us what the top 3.
Okay, so the type of complaints, typically the complaints that we get the most of are standard of conduct complaints, and then unprofessional conduct is the next one. Those are the top 2 related to all of our health professionals that we get. A complaint can go multiple ways. So yes, we may receive 94 complaints, but did they all meet legal sufficiency? So in speaking about the HORA, the complaints, once they are received, it's reviewed by legal, and they determine if there's a potential violation of the HORA. If that happens, depending on what it is, usually each board has a complaint review committee, which is made up of the attorney, the board executive director, and the investigator and the compliance officer. I'm just kind of looking at it like, what route do we want to go to? Do we initiate an investigation right away? Sometimes we don't initiate an investigation right away, depending on the nature of the complaint. So if someone is complaining that, hey, we didn't get I requested my records be sent to my new provider and it wasn't sent, we're not going to initiate an investigation for
Yeah.
that. We're going to send an order to answer to the provider that the complaint is on, letting them know, hey, we received this complaint. Has this information been sent? And that's kind of how it's triaged. So again, it depends on the complaint. Typically, the complaints that render a request for an investigation is something that a standard of conduct, potentially, if someone is saying that the office is, untidy.
Yep.
There's some risk management issue, then, we'll do a random visit, those
Okay.
things. So again, it depends on what the complaint is based on.
So I think we talked about this at some point in the past around when you initiate an investigation, the provider is still able to continue practicing through that part of the investigation. Are there any like a complaint reaches the level of severity where if they are part of, say, a group practice, that you inform the other physicians in the practice that such and such is under investigation?
So typically, no, that is not the case. We don't inform others that someone is being investigated. That part is not public knowledge. If there is a case that is egregious enough, then the Department of Health has the ability to issue a summary suspension. And so those things do get forwarded up to Dr. Bennett for a request to her if we find that someone has done something that we believe would put district residents at imminent danger.
Yeah.
And so those are handled on an agency level. We usually have to make the request to the Attorney General's office. They will say if they are willing to grant our request for the summary suspension, and then it's issued. It will come back to the board once the summary suspension is issued, and then the board may have a formal investigation process to determine the final stages of the license, which could be that the board might decide to do a revocation of that license. They might do a indefinite suspension of that license or put that person on probation.
Okay. Can you provide an update on DC Health developing the certification process for doulas?
That is currently, I just asked my executive director about that yesterday. I was like, where's my doula regs? So that is currently being vetted by legal. So the advisory committee has submitted regulations that are being reviewed by our legal team, and then it'll go to the full board for approval.
Okay.
And then kind of make its way through the routing process.
All right. I want to ask about the High Need Healthcare Career Scholarship Program. So we fully funded this program in FY24. DC Health stated in responses that the grant for eligible training centers would be awarded on February 3rd, 2025, and that money would be dispersed on March 1st, 2025. Has the grant been awarded?
So the High Needs Healthcare Scholarship posting was published in December of this year. We actually received additional funding, and so we modified the posting. So we received Healthcare Finance MOU'd us an additional $5 million for capacity building of our CNA and HHA programming, which is exciting. And so we had to restart our time period. So we did just have that close on February 14th. And we did receive 7 training centers that applied. So the way the money is going out is instead of us giving the money directly to individual candidates, we give it to the programs so that they can run programs. And so we have 2 different kind of arms of this this grant now. There's the training and education arm where we're paying for your we're paying for the tuition, we're paying for your books, we're paying a stipend, we're doing those types of things to support the students. We also have a capacity building arm. So we are working with the ATCs, so the newly, the one coming in Ward 8, as well as the existing one in Ward 5, as well as UDC and other partners and the existing training partners to build out capacity in the district. We have heard loud and clear our need for HHA and CNA training capacity in the district. And so we're trying to bolster that and give funding to these facilities to meet the needs where they are as far as their capacity, their operational capacity.
Okay.
Really focused on testing.
Yes.
Not exclusively.
Yeah.
But we really have been very deliberate about asking about increasing capacity to be a testing site, to act.
Yes, well,
Yes.
that's what I was saying. This came up at the healthcare finance because I think at one point we had 7 testing centers. Nope. No, now we're down to 2 for CNA. For training centers.
Training centers or testing centers? Two
Mm.
different things.
Yeah.
True. Training. Because I brought this up with DOES yesterday as well,
It's
because.
the reduction in the HHA training programs, so not
Correct.
the
Not the
CNA.
CNA.
Yes, HHA. It's all going to be one credential at the end of the day. So we are all sort of talking about the, what, eventually. So this definitely came up. So this is good to hear. Now I got to ask Director Turnage when I see him tomorrow where he found $5 million to send to y'all. Because he told me he's broke.
It was a
Federal
special
dollars.
set aside by the feds for this purpose. So
Okay,
it
okay.
can only be used
Yes.
for this. It's not in their normal stream of funding.
Okay. Well, that's good to hear. You know, I think we have a hearing in March on long-term care workforce. We've been trying to figure out how to sort of deal with this issue of the direct care worker. Some of it is funding, but some of it is the other pieces that we need to do, as you guys know. And it's good to hear that you're working with the ATCs. I'm a real big, I feel like there's such potential in the ATC, especially a Ward 5 location, to really sort of grow out some of this. And now I'm sort of thinking about it. Are you all informed about DOES's pharmacy tech training program
Yes, and they're
with Howard? They're not really doing the training. Howard's doing the training. We're
Yes.
just paying for it. But
and the paramedic, that we've been trying to find what our place is in all of these different training programs. I've been working with the ATCs for quite a long time now to try to help them bring in new partners and do various things wherever we can find a way in which our resources will help either direct things to where the district actually has its needs so that they're planning to match our needs, or in which we have resources that'll push further towards getting actual people in our system. We're doing that.
okay, that's good. I mean, I worry because we've now mentioned 3 different agencies. So I'm like, okay,
Yes.
well, actually 4 if we include OSSI, right? So like, is everybody talking to each other about what is being planned, how much money is being spent, and then also the quality of the outcomes in terms of these training programs and facilities, et cetera? Like, are we seeing the outcomes in terms of their students being able to actually pass and get licensed at the end of the program?
Well, I do want to encourage anyone who's got a healthcare related program to come to us, because there have been levels of complexity around testing and licensing and what you actually have to do to get to become one of these things that are not always as clear from the outside. And I definitely don't want people training people who then we can't license because they weren't at, that program wasn't approved.
Yeah.
So there's more to it than just delivering a curriculum, and we are a necessary partner as soon as possible. So
Yes.
anyone who's got a program that we hear about, we do reach out to them. If you hear of one, tell them to reach out to us.
Yep, Sam.
And that was one of the primary motivations for us using a grant program rather than just contracting directly with the programs, is it creates that accountability mechanism, as you referenced outcomes. That's what we're outcomes based. So making sure that when we give you money, we can have that accountability mechanism for, are you actually having people pass? Are you having people complete the program? Are you having all of those things? There's going to be fallout. Like, we understand not everyone is made to be a healthcare professional. But at the same time, how do I make sure that I'm spending the money responsibly and accountably?
That part is spending it responsibly. And with that, Dr. Bennett, I would ask that you guys touch base with Director Morris Hughes at DOES. And hearing with her yesterday, we talked a little bit about their community health worker program. And I've got some questions about whether or not that needs to continue, given the difficulty of placing a community health worker who is not licensed and anything else in some of these jobs that we have that exist.
We have been talking about talking, and we've had a little bit of interaction, but I will make a point of sitting down with her to see what programs they have that we need to be involved in.
Okay, all right, thank you. Okay, okay, I'm gonna talk about long-term care, but hold on. Okay, so I feel like every day somebody is emailing us about a compact. I want a dental compact, I want an OT compact, I want a social work compact, I want a nurse compact. They want a compact for life. And which are you all currently working on? Let's start there.
So we are currently part of the medical compact, the psychology compact, the physical therapy compact, and most recently, the professional counseling compact.
Okay. Do we have interest in joining anybody else?
So they're a good mechanism if they work for the district's unique configuration. I will give you the example of the nursing compact. The way the compact is written, it really functions well if the compact nurses are a small portion of your total pool. If you are California and you've got some coming in from the edges of the state, but the vast majority of your nurses are internal, that works. For us and really a few other states that are small and most of your nurses are coming from outside, then having no oversight over those nurses, having no ability to truly investigate, having no funding from those licenses to run a board, all of those things become unworkable for us. So having 80+% of the nurses in the district not be related to us in a way that we can oversee them, do investigations, it doesn't work. But we will find workarounds, and we're working on that in order to be able to get the benefits of the compact without having to necessarily sign on to the restrictions which prevent us from investigating independently and doing other things.
Okay. So separate from a compact, we have reciprocity agreements with our neighboring jurisdictions, which I feel like makes sense for us, right? Patients live in multiple places, providers live in multiple places, et cetera. Are there any new reciprocity agreement conversations on the horizon?
So currently, we only have one reciprocity agreement, and that's with physicians. We are starting our reciprocity agreement with the physician assistants and also a veterinary medicine. We have engaged almost all of our boards and with our neighboring jurisdictions, Maryland and Virginia. And there are some restrictions for some of them on if they are able to enter into a reciprocity agreement. There are changes that they would have to make legislatively to do that. Some of them have expressed that they may not be interested because they are part of an existing compact, so they don't feel like they have the need for it. So then we're working internally to look at ways to have an expedited licensure process, more so in our endorsement path, and looking at what substantial equivalence means and just looking at those things. So kind of looking at all of the ways individuals can enter into the profession, and what can make it the easiest, but also ensure that we are following the regulations and having people who are licensed in the district who are competent.
Okay, speaking of expedited, so as you know, the council passed the Certified Nurse Aid Amendment Act of 2024 last year. It became effective December of 2024. When the committee was passing this bill, DC Health reported that it would have an expedited licensure process for Maryland and Virginia CNAs up and running by November of 2024. March is Saturday. What's our delay?
So unfortunately, we have not been able to do that as of yet because of the transition. So our current CNA licensure system is an external system that we have with an external vendor. The plan is to move the process in-house. And initially, we did think that we would be able to accomplish that by November 2024 based on our contract agreement. We had to delay that because we've had to extend our contract in order to ensure that our IT department has enough time to do the transitional work of moving all 8,000 CNAs from our external vendor portal to our internal vendor portal. And then we will have more control about the issuance of the license. It's harder when your kind of staff is working in multiple systems.
So what's the new timeline? Because just as a reminder, like, we wanted to just establish the regional reciprocity. You all said we could deliver on this expedited process, and now our facilities have been waiting.
So we are anticipating that we will have it done before the end of this fiscal year. With the change, we're going to be consolidating. We've started recruitment for the advisory committee so that we can make the changes. But as far as the moving the system internally, Mr. Hurley, I think our game back is, yeah, it's going to be.
I'll have to get back
yeah.
to you because we have to look at IT. We're purchasing we're having to convert a lot of our systems onto new systems for various reasons. And so I have to look with him.
Okay, so what do I say to my nursing facilities, my skilled nursing facility? They've been waiting.
Mhm.
We allowed for this reciprocity during COVID. We stopped. Now it seems like you're gonna say, like, we're not gonna have this up and running until November of 2025. That's an entire year.
Mhm.
So our goal is still with working with staff, as you stated, we have done a great job. I meant to applaud my team for bringing down the processing days. So we're still hoping to, even with using the external vendor, that we're able to process our endorsement applications at faster. So that's still our goal. It's not that we're going to be delaying the approval of the applications. It was just going to be easier for us to do that and be able to clearly identify that we've reduced the time if the system was moved internally. But we are still approving the Maryland and Virginia applications in a timely manner.
Okay, so the Maryland and Virginia applications are still being processed. That is not
Yes.
being,
Yes, it's not
Something
being
that it's
delayed,
waiting on.
no.
but the new system is the delay.
Yes, in the sense of it being internal.
Okay. All right. We did hear some testimony on Monday about the advisory committee. That hasn't been established yet, but that DC Health emailed a small group of stakeholders to apply for the committee and only provided 4 days for a response. Did that happen?
They were given a week. It wasn't a small group. We sent out the communications to the identified group that the advisory committee would be made up of. So it was sent out to all of the Board of Nursing licensee holders like RNs, LPNs, HHAs, CNAs. So all of those groups, which is
Tens of
almost
thousands.
Oh,
30 plus
yeah, if you sent it to all the
individuals.
licensee.
And then we partnered with our facilities division and they sent it out to their home health agencies, nurse staffing agencies, et cetera. We received over 100 applications that we reviewed and have made recommendations that will be going to Dr. Bennett shortly.
Okay, 100 applications in a week. Not bad. Okay. So, oh, hold on. Okay. On Monday, we had heard that Director Hurley, you had told partners that guidance on allowing CNAs to do work in homes would be shared by December 2024. What's the timeline on this guidance?
So we're clarifying those requirements, and we will be issuing that in the immediate. The problem is that we're in this weird phase where we're transitioning to a singular license for HHAs and CNAs, and we haven't clearly established that process of how does a CNA become an HHA or an HHA become a CNA, or they become one. And so making sure that's clear, because what we have concerns about is if we blanket say, oh, you can go function in a home CNA, but there's no training for you to assume the training and skills that an HHA has.
Correct.
Then we're saying they're functionally equivalent and there's absolutely no difference. So we need to provide some guidance of when you do this and you put them in a home.
This is what they need.
Exactly. And
Got
so
it.
that's what we've been ironing out. And it was a little bit more complicated than I imagined when I had that conversation with them.
Okay.
And so that's my whoops, but we are working on getting that together so that we can clearly articulate what you need to do until we do have this merger.
Okay.
And that's some of the pre-work that the staff is doing, kind of looking at both curriculums, both skill sets that's needed. And then that will be the work that the advisory committee will do in order to adjust the curriculum and create one standard curriculum for both professions. And then be able to say, then we'll be able to give guidance not only with creating an application for its CNA, but be able to give guidance to the training programs and what their new curriculum would look like, and then be able to give guidance to what a current CNA who is working could be able to work in the home. And even in doing the work, we know that our Maryland CNAs, if they're a GNA, they pretty much are able to do both spectrums. And so we know that individuals coming in from Maryland have an easier transition into going into the home.
Yeah. Okay. That's the GNA, CNA, HHA,
All the A's.
all the A's. Adding an A, what's the status of proving? What are we calling
The
this?
medication aid.
Yeah. I don't
The MACs.
Yep. It had an acronym. I was like, how are we referring to this? So the
So-
medication aid training.
So there has been no request of any medication aid training programs. There is established regulation for the medication aid license type. We do have a drafted application. It's just hidden or it's hibernating at the moment until we finalize our data sharing agreement for the national exam. One of the things that I know that came up on Monday was just, I think there's some discrepancy between a TME, a trained medication employee, and a medication aid, an MAC.
What's the
And
difference between the two?
It's the
so-
whole journey.
Yes.
So
It's a
hold on.
journey. What do you mean?
Hold on.
A trained medication employee is really something that was designed with the district specifically in mind with disability
Yes.
services so
Okay.
that these individuals can work in group homes for individuals with intellectual delays.
Okay.
A medication certification or medication aid is more of a national space that they are able to
Take it
work-
around.
Yes.
And have a bigger scope.
Yeah, they have a bigger scope. A TME is very limited in scope. They are pretty much your mom. You know that you got a prescription and the person has to take these 2 pills at 2 p.m. They're going to give it to you at 2 p.m. And that's
They don't do injectable, they don't do
Do-
a full scope of medications.
Yeah.
And they are not allowed, by the way that statute is written, to work in other locations.
Except for the group home.
yes.
Yes.
And so
How many of those people do we have?
we have 1,285 TMEs.
So whenever we get our thing together on the MAC,
Yes.
all of the TMEs will have to get recertified?
No,
No.
they'll
Okay.
say
They'll
TMs.
say TMEs.
No, but
that's-
if I'm a
They
TME and I wanna,
Yes.
They should, if they want to, then they
if I
would
wanna
have,
diversify.
they would have to take the national exam. There's no national exam.
And
It is-
additional training, because they
Yes.
have not been trained to do some of the things that an MAC would be trained to do.
Why did we establish a TME?
We established it long ago.
A long time ago in partnership with Disability Services because it was something that they needed within their,
It's been
group homes
decades,
at-
so it's not recent.
yeah.
I don't know how widespread medication aids were at the time that
There
was
wasn't.
done.
I don't think there was.
I don't think they were widespread. That is not a many decades old designation. Lots of nurse assistants have been created over the last 30 years. So we preceded perhaps a bit the national
No,
movement.
I'm just preparing though, because then I'm gonna have 1,000 or so individuals who have a TME.
Mhm.
Who they're gonna, oh, maybe I can go work because I do medication administration over here. And then they're gonna, oops, nope, you need this other thing that's gonna require additional training and you have to take an exam. And they're gonna
Yes.
say, but I've been doing medication for the past 15 years and I've never lost a patient or something.
Yes, and we'll say this is a syringe.
Yeah. Their scope
And
is-
they'll go,
their
oh,
scope
I've never
is-
done
is
that.
slightly
I do need
different.
to learn some more stuff. It's
Yeah.
very clearly a different scope. They have it they are very clearly. They don't do blood, they don't do finger sticks, they don't do a lot of things they would have to do they're things they can learn. And we hopefully will have some of the
Training
medication aid
Yeah,
trainers
okay, so let's-
who will let them do a abbreviated version of the training. We can do some bridge training. That's part of what needs to be figured out.
That's,
before
what
this
I mean,
happens.
as long as I'm hearing bridge training as opposed to you're gonna have to start from scratch.
No,
No, we will.
We're aware of
we
it
will look at that,
beforehand, so
yes.
that's how we're trying to approach starting these training programs.
Okay, so on Monday, someone mentioned that 3 training programs have applied, but they've all been rejected. But you're saying nobody has applied.
For MAC, so
Yeah, for
I know
MAC.
the individuals have applied for our patient care tax, but I am unaware, so I will follow up with my team regarding any MAC applications, because I did ask about that, and I was told that we had not had any applications for any training programs, but I will confirm.
Okay. Do we have any training programs for MAC on the horizon?
Not that I'm aware of, but let me circle back and I will provide that response.
Is this something that we would, I don't know, take a bigger role on the government side and try to partner with one of the universities to establish the MAC so we have at least one?
So, for example, with the PCT, Trinity is the program that is going to have a PCT program, the patient care tech. So I think some local programs that have a nursing program, they are looking at potentially opening.
But we have been having a conversation about needing a more regular conversation between all of our trainer programs and education providers and us as the profession creator.
Yeah.
That they are aware that something's coming, because it takes time for them to spin something up.
Right.
And come up with their
So
curriculum.
that we
and-
can be in.
Because I don't want us to go through this
Alignment.
process of, we are creating
Mhm.
this credential and then nobody can apply for it because there's no training program in the district.
So, and
For it.
and that is, I think, also part of the clarity. So people will be able to apply because there are other, if you're coming from Maryland and you've taken the exam or you've taken the training program. So just like we have endorsement for other license types, so we would have an endorsement pathway. It's just that if you were initiating your education
That's what
within
I'm
the
saying.
district.
If
that's
you're-
the-
I'm
we
thinking
should allow
about the
district
district
residents.
resident who
Yeah.
might want to serve in their community. This is an opportunity that is different than CHA,
Correct.
right? In terms of where you can go job career wise. You know. Okay.
But that's why we're starting these discussions with the ATC, OSSI in general, and UDC.
Yeah.
So it's the beginning of what we're hoping is ongoing collaboration, so that they are aligned in their creation with what we are creating.
Is there an age restriction on MAC?
They would fall into the same category as the NAP, so the 16.
As the who?
The
Nurse.
nurse assisted personnel, the NAPs. my
They all
apologies.
fall under one
That
one
one.
umbrella of nurse assistant personnel.
Okay, do we know what the age
It's
restriction is?
16.
It's
16, okay, okay. All right. We just went through a lot of acronyms there.
I know, so many letters. Sorry.
I wrote a list. PTC,
Patient care
Patient care
tech.
yeah, which the T and the C are,
Mhm.
doesn't match. Mhm. TME,
Trained medication employee,
trained medication employee. MAC,
medication.
Aid
Aid.
certified.
certified.
Yeah.
Certified?
MA.
You know, if it was CMA, we'd have bigger problems, so we're going with AMAC.
Wasn't
Got a
country-based
CNA,
awards.
I got a HHA. All right, okay, all the things. On the AIDS.
Mhm.
Hold on. Okay, one of the issues that kept arising on Monday was about testing.
Mhm.
Whereas these programs, I think for CNA, they've got a class
Yeah.
who's ready to go, and then they don't meet the 5 minimum threshold for the test, or the test keeps getting canceled. I feel like there just has to be an easier way for us to streamline this.
We do not have total control of this. So the testing partner is chosen by the national board. So we don't supply the test provider. We don't decide who it is. They have to go through that window in order to take the test. But I think a lot of work has gone into understanding why this is not working. And so I think we have gotten some real information and ideas about how to move forward. I'm going to let you talk that through, Sam.
Yeah, so we really started unpacking what is going on here because when we talk to Credentia, the provider of the national exam. Credentia, yes. They are the selected national vendor for delivery of the written and skills or psychomotor examination for CNAs and HHAs. When we spoke with them, their reporting to us was that we are only taking advantage of about less than 60% of the available seats that are in the District of Columbia for a test. So there's 40% of the available spots are open. So that is a huge disconnect from what we're hearing from the training programs that says there's no spots for months or periods. So we're trying to tease out the difference. So what we have learned is that there is poor transparency and visibility for the training programs.
Yeah.
So
They don't even know the dates.
they can't log in and see the dates.
Correct.
So what we have done is we have worked with Credentia. So now they will send us a weekly report of every available seat or spot and the test code so that the student can literally search for that specific test code to sign up for it. We will then distribute that to the training centers so that they have direct visibility. So if there is a problem where, oh, this test code says it has 5 seats available, but it says full, then we can go to Credentia and say, wait, this doesn't align.
Mhm.
But there's poor visibility on that side. What we're also seeing is that there are only 4 testing centers. So differentiating between training centers and testing centers, there are 4 testing centers within the District of Columbia. All of those centers both are regional test sites and in-facility test sites. So the difference between those is that in-facility can test their own students, but they're not delivering the test to their students directly. Instead, they are hosting a skills examiner who is coming in, who is a 1099 employee or full-time employee from Credentia to administer the test on their behalf.
It's like we do for SAT.
Yeah, exactly.
Okay.
Come to our facility and take the test.
Okay.
And then we have regional sites where I can go as an outsider and go into that facility and it's not closed off. So it's discerning between availability of RTS or regional test site availability and in facility, because in facility is restricted only to the students that originate from that facility. And so there was a lot of nuance that we had to adjust. So the next steps that we were taking, besides increasing transparency and visibility, is increasing the number of regional testing locations in the district. So
Yeah.
we have worked with the ATCs. So Ward 5 ATC is going to become a regional testing site. Yay! And we are going to, as soon as Ward 8 comes online, that is also going to become a regional testing site. We are also working with our partners at UDC for them to potentially do something because they have the equipment, because they have nursing programming to host a regional testing site as well. And any of the training facilities can also become regional testing sites themselves, so they could host the exam. Again, approval of those sites is subject to the discretion of Credentia. However, we've had direct conversations with them is that it can't just be these 4 in the market. We have to have more.
Yeah, it's not even that 4, because if you take the 2 in site, in facility.
They're
Yes,
doing
in
both,
facility
but
site.
all 4 are doing both. All 4 are doing, they can be both. So all 4 are both.
Right, but you just said
That they
though,
have some
if it
education.
is designated as an in-facility test site, that if I'm from so-and-so's school over here, I can't take my test there because
Right.
I'm
No,
not.
it's
I
each
think
exam.
sometimes they're doing a regional exam, but sometimes they are only doing the exam for their own
Oh,
students.
but
So the
it's not-
availability is not as wide as it
Yes.
seems. What's happened though is, I don't think the process and how it worked was shared with anyone who was questioning or concerned about this, because people could have become testing sites some time ago if this
If
had
they
been
knew.
well understood. So we've done that work now. They understand, we understand, and we will move forward with getting them on board. It is not a long process.
Yeah.
So we will hopefully have people on board relatively soon, certainly before this next class
Do-
graduates.
Does your office have the capacity though to be this like information conduit? I know.
For
they're-
now.
They're the vendor, but like this is a poor way to run a business if you don't tell people when they can take the exam. If the College Board acted like this, they never get paid.
So part of the problem is that the individual candidates are the ones who have access to log in and see
Right.
exam availability. But if they put a zip code that's not near a facility and don't change the distance,
The miles.
yes. So
Lord.
if they don't change the distance, you don't see the exam. And I will tell you, most of our exam locations are in zip code 20018. 3 of the 4 are in the same area. So if you live not in that area and you don't change the mileage, you're never going to find an exam that's available. So it's a confluence of things. In addition, we have also worked with Credentia. They're actively recruiting more staff. So there are part-time position postings on Credentia's website to recruit more. And we are working through negotiations. They're going to have a full-time testing coordinator in DC.
Look at y'all problem solving.
Yay.
You should talk to some of your friends in the cluster. You guys should do this. Identify a plan, come up with a solution, implement it, address the problem. Okay, all right. On that, separate, still related, long-term care, model discharge plan. I've heard some needs from the Office of Long-Term Care Ombudsman. Oh yeah, we'll give everybody an opportunity to shine today.
I have a lot of experts. There's some deep knowledge in all of these people.
It's great.
Come on up.
You just introduce yourself for the record.
Renata Cooper. I'm the Associate Director for the Office of Health Facilities.
Okay. All right. Model discharge plan.
Model
for
discharge plan.
Long-term care. What's the timeline for this?
I hope to be able to introduce it to them this Friday. I have a meeting with Mr. Jones at 10 a.m. on Friday. Again, there has been no statutory or regulatory change. So I've confirmed with our general counsel, we're making stylistic changes. I think the most significant change is that when it was last published, DACL wasn't DACL, like the name was different. Part of the conversation I would like to have with the Ombudsman's office regarding, I think, the model discharge plan and what the intent from DC Health is versus the intent from their office. If we produce a document that is a model of something, it has to be the model of something that I can enforce. I can't produce a model of something that is not a regulatory requirement or a statutory requirement. So possibly, I think the resolution in this would be for the Ombudsman's office to partner to develop a recommendations or something from their side that they want providers to do, and they can publish that. And we can certainly work with them around that. But for the actual model discharge plan that is a requirement by regulation needs to be reflective of what those regulations are. And so some of that has been, I think, the back and forth with their office over time.
Okay. Okay. Look forward to hearing more from when you talk to Mr. Jones, and I'm sure Mr. Miller will bring this up as well to talk a little bit more about that. He also expressed some concerns regarding what he perceives as the lack of participation of DC Health in cases related to long-term care facilities. So when they have a situation where it's a complaint against the facility, you know, they say that sort of DC Health isn't at the table, but you all license these facilities. So if there's a complaint in terms of patient safety, that's up your wheelhouse, in your wheelhouse, no?
It is, if the complaint is shared with DC Health. So the unique seat that we sit in as the licensing entity for the district as well as the certification agency on behalf of the Centers for Medicare and Medicaid Services, we have a unique role in that we proudly go in and do what no other agency can do, right? We go in and we identify the noncompliance. We hold the facility accountable for licensure and federal requirements, and then require them to submit a plan of correction of how they're going to remedy this to make sure that it does not reoccur. The difference with the Ombudsman's Office is that in working with patients, residents, and their families, they're not required to report to me if someone were to express a concern to them. That is by law. They have to have consent from the individual to share the information.
To share the complaint.
Yes. So if you're a resident in the facility and you express concerns regarding timely care, they can work with the resident, work with the facility administration for resolution, and I may never hear about that because it may be resolved.
Interesting.
So there's not a requirement that it comes to me. I think in watching the hearing on Monday, one of the concerns, the case that was being referenced, DC Health was at the table for the capacity that DC Health acts as the regulator. So when the complaint was shared, DC Health did a formal investigation. There were status conference hearings regarding that particular resident where our representative, which in those hearings is our general counsel, attended every hearing related to that case. I recall having very specific conversations with Mr. Purley as well regarding the incident. So again, on Friday, I hope to hear more of what their expectations are and also share more from our side, how we view our involvement in certain cases, because we're not a case management entity. We certainly can hold facilities accountable from the perspective of the regulatory requirements.
Yeah.
But some of the day-to-day conversations with providers or with the residents or family members doesn't necessarily always need this level of engagement from our
Sure.
office.
And I would definitely, yes, on that front. I would think though, if one of our ombudsman offices are receiving enough complaints that is starting to show pattern or practice, I would expect that they would forward that information on to DC Health, as you are the entity who could do more than they can, which is they can mediate an issue, but you can enforce a response.
Right. We do attend the meetings, their biweekly meetings. The program managers actually in my office were the ones responsible for attending those. At times, he may reach out to me directly. If there are issues that rise to my level after those meetings or follow-ups, if one of the program managers wasn't available, because I have a program manager over Intermediate Care Facilities Division and one over the Healthcare Facilities Division. So depending on whose area is brought up, usually I'm made aware and I can do some follow-up. But I'm not aware of any outstanding concerns.
Okay.
And so that's why it was really pressing for us to have some further engagement with him this week to figure out how we can best serve the residents of the facilities and see if there's any places that we have some blind spots that we're not aware of so that we can very quickly bring those areas to resolution.
Great, great. While you're here, got some questions on facilities in general, talking sort of separately from long-term care, but related. So you all reported there were 2,453 licensed nursing home beds and 1,162 assisted living facility beds in the district, but that the agency does not monitor how many facilities are currently at capacity. Who does monitor that, if not you?
So we are aware of what our licensing capacity is, but what their day-to-day operational status, that's not reported directly to DC Health. I do know, and Mr. Hurley can certainly chime in, that's been some conversation within our agency regarding the health system itself. And so looking at full visibility of the healthcare system in the district and looking at ways that we can create further mechanisms for our providers to report in real time, as much as real time can be, because admissions and discharge occur multiple times a day. But being able to have the visibility of if this facility is licensed for 150 beds, but because of staffing concerns, they've closed a wing, you don't have actually 150 beds for us to use in the event of an emergency or what have you. Also looking at, when we think about capacity, what their surge capabilities could be. When we do our initial licensure inspections from a physical plant perspective, we're measuring rooms to determine, can this room actually accommodate more than one person
Mm,
You may use it for one, but do you have the capability of going up if necessary? For some facilities, they do look into that in their initial process of opening. And then if that is the case, that would be a partnership between the Office of Health Facilities and the State Health Planning Administration to determine if something were to occur in the district and we needed to expand, we would know where those areas are in our different facilities where we can increase bed capacity, even if just for a temporary stint.
I guess from the health systems perspective, the question I sort of have is like, I think our visibility into what our capacity or capability is actually quite limited, right? So when I talked about earlier around the behavioral health dashboard, one of my frustrations there is that when I would ask, Dr. Bazaran, like, you guys send, if a parent calls or a family member calls and they're trying to find, there's no one who could say, no, call this facility right here because I know they have capacity, but rather we just give you a list and then we tell you to call 7 places and none of them might not.
It just, I think in the past, what we have, which is a commercial system for healthcare, we have not really taken a role as government in managing that system. We just haven't. So the authorities that I would need, the regulations that would tell people how to let me know and when, they have not been written, and we don't have them yet. We are looking at what we would need to do to fix the problems that we're seeing.
Okay.
So if you're telling me we're out of a particular kind of bed today, which is now an emergency, how did we get there? How come I didn't know that last week? So what are the things that we would need to actually help our health facilities serve their role, not get into trouble of being over capacity, not fail to meet their needed capacity to keep themselves financially viable, and even who is in our community, because we don't actually have awareness of all of the different kinds of facilities that are in the community or whether doctors are practicing or not. So we don't really have what we need right now to answer some of those questions,
Okay.
because it had not been the perspective of the government that was our job.
Right.
I think post-COVID and post lots of really critical lack of capacity in the system, we're realizing that is no longer true.
Yeah.
And so we are working on what does that mean we need that we don't have. And so you'll be seeing that from us as
Okay,
time goes forward.
that's good to hear. I mean, I'll suggest or offer to folks who might be listening like, oh gosh, like this is not a far-fetched idea because we do have some insight into, say, ERs, right? So we know, or FEMS rather, knows, okay, Howard doesn't have any space in the ER, so we need to divert to so-and-so or such and such, right? So there is a level of information on some of this. So I don't want anybody to think, oh, big government. But I do think it would be helpful for us to know on nursing home beds. And in another thing, when I was talking to Mr. Miller, the long-term care ombudsman, we were talking specifically about CRFs. Ooh, I'm gonna get this right, maybe. Community residential facilities. And he was noting that I think we just lost 7. And I'm like, okay, well, how many people is that we had to move? And the calculations and sort of the capacities of that, but also without that monitoring of who's leaving the system, how do we know where we need to incentivize or double down in terms of our recruitment to get our capacity back up? That type of thing.
So there are different kinds of information that we need, and we don't want to burden facilities in a way that will just make more trouble. But we know we needed to know about ERs because we don't have the time for it to be wrong, right? We're in an acute emergency. I can't be going hospital to hospital
Looking for a bed.
because something bad will happen.
Yep.
We have just realized, and I think our health facilities have really fed this back to us too, that for them to function, because we're so much acuity has gone up, so much more need has grown in the community, that they need our help in making sure that we can move patients around so that they have the availability they need to serve that need. So there are things that we can do that will help our facilities function better. And that is what the exchange is for the information in order to serve that role. So we're in conversation all together about what that might look like. And I do think there is a future state that is different. And figuring out what that is one of the things that we strategically are going to focus on.
Okay. In the responses, DC Health reported that the agency is developing new regulations for specific standards for psychiatric services and stronger drug screening requirements in suspected cases of overdose. Is this in response to concerns we've heard about current inpatient psychiatric facilities? And what's the timeline for this?
So regarding the psychiatric regulations, I think we, Chairman Henderson spoke with you during the roundtable. The district's licensing regulations for hospitals for psychiatric services have not been for hospitals with psychiatric services. The district licenses hospitals, general specialty, but there's not a specific carve out for a specialty hospital that is a psychiatric hospital or a specialty hospital that is specific to ventilator care. So somewhat due to some concerns and based on what we've seen through our monitoring of licensure surveys and complaints, there is a greater need for the district to have some local enforcement authority and oversight in that space that is more specific to some of the things that are nuances that those hospitals may face that an acute care hospital may not. And so we're looking heavily at some of the structure that exists in the district, maybe through another agency. There's some parameters that they have, as well as some federal requirements that where there is some very specific instructions of that hospitals are supposed to follow their regulations, but they are just not housed under local. So while we can go and do the investigations, we can go and do the surveys, when we look at the enforcement mechanisms that we have locally, because in some ways that we've identified that we're maybe not as pleased with the limited authority, even under federal, we want to be able to have some teeth there. And so we're working with our Office of General Counsel. They've been doing some market research of just the federal regulations as well as what we are seeing in our tri-state area, like Virginia, Maryland, and other states that are of similar size, to see what additional items that we may want to produce. So our hope is that we can have something to you all by the end of this fiscal year of at least having engaged in some conversation, let you know what we've come up this far, and then see what you all may have as far as comments.
I forgot that we did talk about this at the roundtable. Specifically on inpatient psychiatric facilities and sort of the unique limitations that sort of exist there. Okay. One other question in sort of the facility licensing space. So we noticed in the pre-hearing responses that there was a grocery store in Ward 8 that was fined for failure to report significant loss in drug inventory in the required period of time. The fine is what the fine is, but was there a corrective action plan that was put in place for this facility?
It actually does not fall under me. We may have to follow up. I don't recall the specifics around that one, but we'll follow up with our pharmacy division because I think that fell under them if it was drug related. It's just a pharmacy in a drugstore.
Yes.
So we can follow up and get you that specific information.
Okay. The particular community where we've seen a lot of overdoses. And so the fact that you all, whatever happened was significant enough for a fine, I want to understand what practices have changed at that pharmacy to ensure that it doesn't continue in the future.
Okay, no problem.
Awesome. All right. Gonna move on to Environmental Health Administration. I think you're the last administration. Congratulations on being also new-ish. Okay, so I'm really excited about the work of the EHA, but also that we're also thinking about this, right? When we talk about health, people think that we're only talking about hospitals and doctors' offices, et cetera, but not the other environmental pieces that are part of it. And some of the work that in creating this administration, you're taking over some environmental health initiatives from Department of Energy and the Environment. Can you talk about that transition with DOE and what are some of the initiatives now that we should look to DC Health for as opposed to DOE?
I want to give you some context before. So I think the way I want us to think about this is in terms of layering care and concern over the same issue, but from different lenses. So we are interested in an environmental toxin and where it is, getting rid of it, trying to figure out how it got there, and making sure that people aren't in contact with it is very clearly DOEE. That is about how do we interact with it. What I want to be sure doesn't get missed and that we can bring to the table as DC Health is what happens to those people. So when people have been in contact with that toxin, when providers need to be alerted that that has happened, when we need to be following, did care happen in the way it was supposed to? Are there other people at risk? The public health response of saying, who are the people at risk and how do we go find them? I want to be sure that that part is done to the highest degree of both public health authority and public health standards. And at the moment, we haven't been involved in some of these things that I think we should have been involved in. So pediatricians worried about an asthmatic. We are not the people, even though we're who they know as a department, we don't have that availability for them. So being able to take our knowledge of the medical community and of health conditions and our connections with healthcare and use that to make sure that the health system is doing what it's supposed to and that we are addressing environmental threats and harms that happen to the people in the community to the highest degree. So that's where we're going. But there's a lot of duplication, at least in the language. So I want to be sure people understand how it can be close, but not the same. Go ahead.
Yes, Arian Gibson, Senior Deputy Director for Environmental Health Administration. So I'm also going to ask our Associate Director, Ms. Amanda Richard, to come up. She's uniquely qualified to talk about this as she did come over from DOEE. Yes. But just as a general rule, think of it as we deal with the people part, the cases and things of that nature. But Ms. Richard will get into specifics of what each agency handles.
Okay.
Hi, good afternoon. Amanda Richard, detailed through DOEE, but currently with DC Health as the Associate Director of the Office of Environmental Protection.
Okay, so you're just a detailee?
Yeah, our whole team.
Until you pass the legislation on
Yes.
creating environmental health and moving them. That had to be done by legislation.
Keep going.
Yeah, so I've been with DOE for almost 10 years now in the same program, the Healthy Housing Program.
Okay.
There are two programs within Healthy Housing. There's the Childhood Lead Poisoning Prevention Program and the Healthy Homes Program. So they're two separate programs, move slightly different from one another. Under the Childhood Lead Poisoning Prevention Program, there is a requirement that all children in the district under the age of 6 are screened for lead. That is the one program that is coming to DC Health where we monitor the blood lead levels. We do work in tandem with DOEE still with the risk assessments. That team will remain at DOEE. I know during the hearings, there were a lot of questions about how that's going to look.
Yeah.
Even through our detail, it's been the exact same. We still work with them. There hasn't been any breaks in service. Our phone numbers are the same. Our email addresses are the same. Nothing has changed, but we are still able to manage the program without any interruptions.
Okay. We've been joined by Councilmember Zachary Parker from Ward 5, who's a member of this committee. Thank you. Come in. So great to see you. Let me just finish my question on Healthy Homes, and then I'll turn to you. So in terms of Healthy Homes, will the program still have the same staffing capacity? Did the whole team just detail?
The whole team detailed, however, they did retain 2 of our public health analysts that do case management at DOEE. So we do have 2 vacancies.
Okay. So what does it look like now that, well, I guess the question is, how do we promote that it's now at DC Health and not at DOEE so folks don't get confused? How are we?
So back in October, we had a press release at DC Health where we spoke to the public about that. At DOEE, we have a Healthy Homes Digest where we put that information in there as well. And we have informed a lot of our stakeholders.
I will just say we have direct connections with the providers
Okay,
that
great.
are quite strong. So that is who needs to know. We do need to let the community know, but most of our relationships in terms of the person getting the lead test that triggers them to be known happens at a provider office. So I think we'll be using some of the DC Health mechanisms to do
Okay.
that.
And just for clarity for me, based on the testimony on Monday, I'm not a scientist, so I wouldn't know this per se, but when you all get the results back on the blood testing for a child, there's not a way for you to distinguish where the lead came from, correct?
Not through my team. So what we do is when we receive the blood lead result, the reference level is at 3.5 of lead in blood. We ask them to go back, if it's a capillary, a prick through their finger, for a confirmatory test, which is a venous draw or a second capillary. If that level is still at a 3.5 or higher, then that's when we get them into case management, and we'll ask them questions about if they've done any recent travel outside of the country, what type of foods are they consuming? Is there any chipping or peeling paint in the home? We do have access to DC Water's website where we can check and see if their lead pipes potentially have lead in them as well. Then we'll reach out to DOEE's risk assessors, and they will schedule a in-home assessment, and that's when they actually test the soil, the water, and the paint and collect dust wipe samples to see if there's any lead in the home. Now, if during our investigation, they say they spend time at like a grandparent's home or a daycare, then they can also go there and see where the exposure may have come from.
Okay. For other types of healthy home initiatives, like the residential electrification retrofits for low-income households, is that staying
DOE.
at DOE?
Mhm.
Okay, that's good to know. All right, I'm gonna pause, and I still have questions, so don't go anywhere. Oh, I mean, you might, because I don't know what Councilmember Parker is gonna ask, and there's a wealth of expertise in the room. But when you're ready, Councilmember.
Thank you, Chairperson Henderson, and you all are rolling pretty deep today.
I have a lot of experts.
Yes, I
A lot of
appreciate it.
experts.
I appreciate it. I want to start with HOSTA and just rates of HIV and other sexually transmitted diseases. To level set, what's the status of the latest report?
The latest report was published on our website at the beginning of this month, around the 6th of February. And so it is available to the public right now.
Okay, I'm on the website. I don't see it, but that doesn't mean it's not published.
Okay, I will pull it up.
So if
and-
you
and
could
bring
help
it to
me
you.
find the link, I would
Yes,
appreciate it.
I will do that.
And I know we've talked about some of these trends, so this is more of a moment, an opportunity to lift some of that up for the official record. And can you characterize what we've seen in the district from last year or since the last report that you published?
Yes, we have seen a significant decrease in our HIV rates. We're down under 200 for the first time since the 1990s.
That is a big deal.
That is a big deal.
I don't think I heard you. Can you repeat that stat?
I was gonna say, Councilmember Henderson clapped us up earlier.
Oh,
I
I missed that
appreciate
moment?
it. Yes, but this
Okay.
gives me a chance to shout out my team
Okay.
because they are the ones who really do the work.
You were supposed to tell me you all had already covered
I'm
this.
sorry,
but,
yes,
no,
we
shout
already
your
covered this,
team
but I
out.
do want to shout out my team back at HOSTA because they do a lot of work. They are great subject matter experts and they
Yes.
do all the things to make sure we reach the community and we're accessible. So
And
shout out to the
what
team.
are some of the contributing factors that led to that decline?
I think we did a lot of community engagement to inform our Ending the HIV Epidemic plan and to really look at what we were planning to do and how we were planning to do it. I think we listened to what they said they needed and we implemented programs that met some of those needs. We can't meet all the needs, but we met a lot of them. And I also think our programs are responsive. We have community partners that are very great at getting in touch with the community and engaging people and keeping them in their care. And I think the community trusts the community partners that we fund.
I will
Awesome.
just add, because you're not saying it, this is a team that I think is very forward pushing.
Yes.
So Doxy PEP and long-acting PrEP, and if a tool comes on the scene that will help people not get HIV or not spread HIV, they are on it and they are pushing it out into the community as soon as possible. And I think before many other jurisdictions have done that.
Well, you all certainly have a lot to be proud of, and it is my hope that we brag on what we've accomplished as a city more, not from you, just you all, but as a council, the mayor's team, because I do think just given where we've come, it is a lot to celebrate. Given what you just talked about, Director, I did want to highlight the ADAP program. where it's my understanding individuals can gain access to PrEP in particular. I was shocked when we met offline that I think there's a handful of individuals that are participating, less than 5. How can we, or what efforts are being taken to expand access to that program?
So first, let me just say that our ADAP program runs a parallel program called PrEP-DAP. It stands for PrEP Drug
PrEP-DAP,
Assistance
that's what I'm
Program.
talking about.
PrEP Drug Assistance Program. And it is a payer of last resort program. So I want you to know that it is not the first thing that people come to. It is kind of the safety net to catch people when they don't have any other coverage to get PrEP. So we initially worked to get people into patient drug assistance. We initially worked to get them insurance if we can, if they don't have it.
Do you have stats on how many individuals you've helped funnel into other avenues, whether that's insurance or other assistance programs?
Yes, we can get that for you. I don't have it before
Okay.
me today, but
Because
I
I
can get
think
that
when
for
we
you.
talked, there were only 3 individuals participating in that PrEP-DAP program.
Currently, yeah, down from, it was very significant utilization in 2020 when the pandemic hit and people lost coverage and there weren't as many places to
Interesting.
get coverage
Okay.
from. And then it has taken a decline as the world has opened back up and people have returned to work. You know, with everything that's going on now, we might see an increase again in the coming months. That's something that we're looking to monitor and to understand and be prepared for. But it is a safety net program. It is not meant to be your first go-to, but it is there for people if you're under 26 and you don't want your parents' ELB to show that you're taking PrEP, if you don't have any other coverage. You know, there was a time when there were a bunch of prior auths and it was hard to get into patient assistance programs, but all those things have eased. Right now, there is no prior auth for Medicaid. There have benefit exchanges working on adjusting copays and making the labs and things that you need to get on PrEP free for people when they come on without a copay or co-insurance. So there are other things happening that
I
is
hear you.
opening up the landscape for PrEP for folks. So we don't think that the decrease in utilization is alarming. We think that it is because there are other avenues to get the PrEP that people need.
Okay. I will look out for those numbers because something I'm wondering about is, are people even familiar with the program? And are the numbers also informed by people not reaching out because they just don't know that resource is available to them? So
The other way that we make sure people know, I'll just put on the record, is through case management. So at the organizations that we fund, and we fund a lot of status neutral programs, which are programs that have no wrong door to come into. So whether you're HIV positive or negative, you'll get case managed and get connected to services as much as we can through the same organization. There was a
Understood.
time where you had to go to different ones depending on what your
Understood.
status was. And in those programs, they can enroll people into PrEP-DAP as well as ADAP. And so that is where the majority of the applications for ADAP and PrEP-DAP come from, is from community partners and their case management.
Okay. Well, thank you. Thank
Mhm.
you. And Director, I wanted to pivot to infectious disease generally. Something I've been concerned about with this broader federal move to dismantle, discredit, undermine national organizations like the CDC. What guardrails are in place for us as a district to prevent widespread infectious disease?
So we all, I mean, all of the big cities, all of the other states, I meet with all of those people at least once a week. We all depend on the CDC as an expert backstop to keep aware of what is changing. I can't watch I can't watch avian flu as it happens in other states and changes, and we're looking at which strain is now worse than the other one. So I cannot do all that as
Yes.
DC. So we do need them to do that, and
But it
they
sounds
have.
like you are participating in a weekly call of sorts.
So the CDC has resumed its regular
Oh.
calls about most things. So we are hearing about avian flu again. We have a regular information about Ebola that's happening. There's new information happening all the time again. There was a brief pause, but which was alarming, but it did pass.
Got it.
So we all still depend on them to do that, and I don't think anybody else can do
And
it.
is
So
there-
hopefully that will continue.
Has data sharing resumed?
Yes, it
Because
has.
it was my understanding that the websites had been taken down where
Some of those things have not come back.
Okay.
And that's not, some of it's been copied by other people. I don't think there's much of anything I couldn't find if I needed to. But our connections are much more direct than that for the most part. That information is helpful, but in many ways is for the community and for providers who are struggling with an individual patient. We have a need for a much more robust communication, and that is weekly calls and information coming out on a much more robust and rapid pace, and we do have that now. What we don't need, what we do have locally and will retain, unless something very crazy happens to funding, is the investigative capacity to be able to participate in that national goal of being able to look for disease, to stay aware of where it is, to alert our neighbors when we've seen something that they need to be aware of. We are part of the nexus that looks at where international travelers coming from places where there might be things. Dulles is right there. DC is right there. We are part of the international system of surveillance around what kinds of infections we should be worried about, and we are part of the national system. None of us can do that alone, but there are other connections between us. The CDC is just the oldest, the most robust, and the one that I think has retained and built so much expertise that it can't be easily replaced.
Understood.
But
And
we
in my
have our local investigators. We will keep them unless something radically changes with the federal funding. And then we will have to figure out what we can do locally.
A quick follow-up. I know I'm at time. What is our threat locally of having a measles outbreak? I know I hear about it at a distance in Texas and some other states. Can you just talk about what's happening here locally, what we should be mindful of?
So what has happened nationally for the most part, I think, and not in this case, most of the time it is an imported case of measles from a traveler, either usually an American who's gone somewhere who has either waning or no immunity and comes and brings it back. The communities in Texas, like many where we have big outbreaks of measles, are in communities that have really low measles immunization rates for various reasons, political, religious, whatever. We are in a good place because we don't have a big reservoir like that. We don't have a community that just wholesale doesn't immunize. And we have done an amazing job, thank you to the school system, thank you to OSSI, and thank you to the DC Health team of immunizing our kids. So we were lagging near the very bottom of national stats on getting our kids immunized. And that is a real significant reservoir of where we would get a measles outbreak. And now we are right middle of the pack. I'm looking to go a little bit higher in that pack towards the top, but we are now in a range where we feel much safer about not having big numbers of people who have not been immunized, who could foment an outbreak that would really be damaging to the community.
Okay, I have more
We're in
questions.
good shape.
But thank you for that. Yeah. Or should I keep going now?
It's fun to have other colleagues at this, and those were definitely good questions. We didn't cover anything about the measles and avian flu. Fun fact, in 2006, I was an intern at HHS the first time we had a big bird flu situation, and I was in the public affairs office when ABC decided to do a made-for-television movie called Bird Flu in America. About birds dropping from the sky and all kind, like that week was wild. Someone should go find that. 2006.
The price of eggs is scarier at the moment.
What now?
The price of eggs is scarier at the moment.
I know, and they're surcharging. I was at Waffle House a couple of weeks ago, 50 cents
Well,
per egg.
They kind of have to for the price until we get this under control.
I understand, but
And
Waffle
have
House
a
is
better
usually
egg
like,
supply. We're gonna have to.
Consistent. Exactly. You go to Waffle House for consistency, not for surcharge.
$8 a dozen.
Anywho, okay, back to environmental health. Okay, it was mentioned that the team was detailed, but that there's legislation, but we don't have it. So when's it coming?
You get to talk, Carl.
Hi.
You want to introduce yourself? You've been sitting for all of this time. Introduce yourself for the record.
Hi, it's Carl Filler, Chief of Staff at DC Health. Yes, we have to make the detail permanent through legislation, so we're working on that. You should see that in the near short term. So
Okay.
just have that to you shortly.
Okay, great. Okay, Director, you mentioned in your program about an upcoming carbon monoxide prevention program. Can you speak more about the scope and focus and the implementation?
That was a grant that we
that's a grant.
pursued,
Okay.
and I'm going to let our new director.
Yes, so that was a grant we received. Thank you to CPPE. They actually applied for us and gave it to us. Thank you, Brittany. Yeah, so basically it is to provide education and to actually provide carbon monoxide detectors to our vulnerable population. And specifically, we want to provide the carbon monoxide detectors that will detect low-grade carbon monoxide. So most of the models that are on the market now are UL certified, and in that certification, they only alert you when it has been 60 minutes of an exposure of 70 parts per million or more. We know that there is a such thing as acute carbon monoxide poisoning.
Yeah.
So we don't want to wait 60 minutes, So we are trying to disseminate carbon monoxide detectors that will, once you get to 87 parts per million for 15 minutes, it will alert you.
Okay, so that would require us uninstalling existing, if a home already has an existing carbon monoxide?
So we're not asking anybody to uninstall or not, or take down what they have. Our focus is on getting these carbon monoxide detectors in the homes that really need it. So a lot of the targeted areas we are targeting have older homes that might not have any carbon monoxide detectors.
Okay, got it.
And also it's to populations that really need it. So populations with age groups under 18, children under 18, and the elderly.
So just as a general sense around what is going to happen with environmental health, most of the things that are environmental threats are not threats equally to everybody.
Right.
And so just like heat or frankly COVID or anything, there are groups who are going to be particularly vulnerable, and we may not have solutions. We may not need something for the whole community, but there are people, the elderly, who that longer term detection is going to miss things that would affect them that maybe wouldn't be a danger to adults in a different household.
Okay.
So we want to make sure that they have the higher level that they need based on their higher risk. And we're going to do that with other kinds of environmental conditions as they come.
Okay, is DOEE holding on to mold? And obviously,
We haven't discussed it, so we can.
okay. It's sort of in the ongoing of, is it DOE, is it DOB? Obviously, identifying mold in buildings is one thing, but the health impacts is something entirely different. And I mean, eventually, sometimes it does end up at the Attorney General's office because we have a landlord who doesn't properly abate and sort of deal with that. Okay, I want to go to food safety. Now, when I brought up food safety two years ago, we had a real awkward conversation about food safety then. Yeah, I want to acknowledge that the team has made some progress on the number of required inspections that you were supposed to complete in fiscal year 2024. So that's at least one inspection at each hotel, restaurant, school cafeteria, and delicatessen. And data shows that for the restaurants, however, DC Health conducted about 3,200 inspections for about 2,600 restaurants. Does that mean that every restaurant was inspected at least once, or did some get inspected multiple times when others did not see an inspection?
So most likely some of them got inspected multiple times, whether it is because of complaints or because of their risk level. So again, we try to prioritize the high risk levels, those who serve highly susceptible populations, those that may serve raw and cooked foods, things of that, or those who have a poor inspection history. We will raise their risk level.
Okay. So do we hit everybody at least once?
I cannot confidently say that we've inspected every single restaurant at least once.
Okay.
But we did inspect the ones that were high risk levels. So there may be some restaurants that have been great over the past 5 years and we lowered their risk level.
Okay, so there were still some areas where we didn't hit what I'm going to call solid numbers. So caterers, we only did about 39%, food production 60%. Why are these lagging behind some of the other entities?
Yep, so two different situations. Caterers is kind of unique because they're only there when they have an event. So if you have a caterer and we go to your facility, if you don't have any events there, typically you're not going to be in there working. So we'll leave a notice of contact information, but people don't always come.
Hold on, so for clarification, for a caterer though, you're not doing the inspection at the place where they're prepping the food?
Yes, but they only prepping the food if they have an event.
Oh, I see. Okay, it's not an ongoing
Yes.
continuous thing. Okay, got it. Okay.
And for food products, those are very low risk. So food products only sell prepackaged foods. So we consider that very low risk, although things can happen, such as a food recall and things like that, but it's very low risk. Typically, you're not going to get sick from a bottled water or a bag of sealed chips.
So when you say y'all's definition of food production is around for prepackaged.
Yes, the category food products are only prepackaged foods.
Okay.
So that's not a high priority.
All right. How has hiring gone with this division?
So I'm happy to announce that for the first time in about 10 years, we're fully staffed. So yes. Yeah.
It's hard. You
Yes.
explained it. It's really difficult to find these folks.
Yes.
You're not just looking at a checklist. You got to actually have some expertise.
Yep. So two things. One of the major things that we did is we changed the more recent postings from sanitarian to inspectors/investigators. Sanitarians, you have to be able to inspect every type of facility, whether it's a hospital, swimming pool, whatever. And so it's a lot more credentials involved. Whereas for investigators, it's specific for food. The other thing that's kind of unfortunate right now is in the past, we were like a training ground for the federal government. We would hire them, train them for 6 to 8 months, and the federal government will come in with their federal government salaries and hire them away. We're not having that problem right now. And so,
Guys. That is a silver linings in some places, I guess.
yeah, it's
Okay.
unfortunate, but yeah.
Okay. I don't have enough time to launch into the next piece here, which is going to be about cottage food and street vending, and it's going to take some time to unpack. So I'm give some time to Councilmember Barker.
Thank you. I want to go to school nursing. Has this been covered? Okay, I'm gonna add, we can just go through the questions quickly then. Have there been any shifts in the ratio of RNs to all other health professionals participating in the school health services program? And for context, I'm aware that you all are using the cluster model where there's one RN supervising and working alongside other health professionals is how I would define it. The question is more about like, have we lost RNs over the last year, or have we been able to hire more RNs to shift that ratio?
We've lost some and we've hired some, so it's a change of
constantly
about
shifting.
13 staff.
Change 13, like we're down 13.
Correct.
Okay, that's concerning.
It is.
And so then another question was going to be progress in hiring. I'm assuming, well, let me ask, what progress in hiring RNs have we made?
So we have made good progress with hiring the RNs and being able to staff up the number of planned RNs. We still have some significant vacancies with the LPNs, and we discussed that a little bit earlier. But we are also working on other plans for, recruitment bonuses, retention bonuses, other ways that we can be more competitive in the market.
And we talked about
We
that
talked
last year.
about, right,
Yes.
we did lose several staff to PG County, which we've discussed, and so we
Okay.
are.
What is your
continuing to-
timeline for that when you're thinking about bonuses and incentives?
I mean, planning that with the,
budget.
yes.
Got it. So anticipated fiscal year 26, ideally, which, okay, that is helpful. How many schools are receiving at least 40 hours of nursing coverage a week?
So all of them have 40 hours planned. I'm sorry, are you talking about health suite staff or specifically of the RNs?
Health suite staff.
Just
So
any
it's my
staff.
understanding that no one's
Yeah.
receiving 40 hours of RN coverage.
Right, I just wanted to clarify.
Yes,
Yeah,
yes.
Yeah, so right now, I think we're over 87% covered.
So more than
But we still
87%
have-
of our schools are receiving 40 hours of coverage a week?
Correct, right, correct. But that is a mixture of staff, and we still have some challenges with call outs and being able to provide coverage. So
Got it.
we have not been able to keep up with replacement of staff when they call out. And so a lot of schools often end up with phone coverage when their staff person is not there, but we're continuing
Phone
to work with
coverage,
that.
in other words,
So like the nurse manager will be available to
talk to the young
communicate to the
person
school,
via
right?
phone.
Correct.
And in those instances, let's say I have a bloody nose. What's the protocol? I'm a kid, I have a bloody nose,
The kid is not the caller, it's the staff.
or the staff is saying I
So
have
the
a kid
staff
with a
at
bloody
school
nose.
is calling to say,
Staff.
what should I do in this situation? And they're being talked through what to do, just like if you call the nurse advice line
But
yourself.
what would
for your
happen in
child.
that situation? Is it called 911 or is it?
No, they call the number they've been given
Right.
to call when their staff
For the
person's
nurse
out,
manager.
which is
No,
a
I
nurse
get
manager.
that. So
Okay.
I'm saying, assuming I'm on the phone with the
Mhm.
telehealth representative because I don't have someone in my school.
Right, or the
And if
nurse
there's an
manager.
adult that's saying, I have a sick kid,
Mhm.
either because it's blood or some sort of illness, what happens
They would
next?
tell you what to do. So we're going to put something on their nose. We're going to hold pressure in the right place. This is the place. Hold for 2 minutes. Let go. Has it continued to bleed? If not, let's try one more time. They talk you through it. If
Mhm.
you've got a kid who's got a nosebleed that won't stop, which would be a really unusual thing, just like you would at home, you would then need to get a higher level of care. But most of the time, the simple measures will work.
And what impact is there on liability with something like that? I'm on the phone talking to a health professional that's telling me to do something. Does DC Health or that health professional assume the risk? Is it on that adult that's providing the care?
We'll have to talk about that because I'd have to, I don't want to make a legal pronouncement that I don't.
I mean, that's
don't
my
have the
immediate
authority to make.
concern. If it's a serious issue that the health professional is advising, and maybe a bloody nose isn't as
Yeah.
serious, but if there's something else, I can imagine.
I think if it was something else and were more serious and it wasn't clear that it was something like a bloody nose, they would have you call a higher level of care.
Got it. Like 911.
Yes.
Understood. Oh, so if we're at roughly 87% of schools with at least 40 hours of coverage, is it safe to assume at least 100% of schools have at least 30 hours of coverage?
Let's see, I'll have to look at it, but I think we were around there. I think we were close.
If you could follow up
Yeah,
with those
yeah.
numbers, as you know, Councilmember Henderson and I introduced legislation
Mhm.
to set the watermark at
At
30
30.
hours a week.
Mhm.
I don't believe you all were at 87% of schools having 40 hours last year.
We
So
were.
that seems like you've made a significant
I think,
gain.
I think we were exceeding 30% the last time we met.
You mean
about
30
it.
hours? We
I'm
were
sorry,
putting that
30
number for
hours.
30
Yeah.
hours.
Yeah.
Okay. And part of the pushback we've heard from others is that they want all schools to have 40 hours a week. We all want that, but there's clearly constraints. So thank you for that. One last thing, what progress, if any, has been made in providing health coverage for after-school activities? That too came up last year because it seemed like the nursing suite is shut down around 2 or 3 o'clock, even though a school may remain open until 5 or 6 o'clock.
Right, so as far as the CSS program is concerned, that is the end of the day for them. However, we have been partnering with our ed sector partners, DCPS and public charter schools to help assist with more AOM training for personnel who are working after school.
Okay. I will just say, I'm not satisfied with that, but I get where the constraints are.
And that's where we are now.
Yes, I
right?
get,
But yeah, there's
so
more
hopefully we
more work
can
to do.
move towards more professional coverage in those after-school hours as well.
We will continue.
I believe this has likely been covered, but there are currently vacancy rates, so I'm pivoting. There are currently vacancy rates exceeding 20% for 4 of the 6 administrations under the agency. And what progress is being made here in filling vacancies?
So we always have flux of people, when we moved, when people move to federal jobs, there's always flux. I think we've been actually doing a fairly good job of getting vacancies filled. I'm not sure I believe everybody's at 20% anymore.
Okay.
There were several big rushes of trying to fill positions. So
Are there any
recruitment of
hard
some
to
is
fill?
difficult.
Are there any hard to fill positions?
Epidemiologists are hard everywhere. Statisticians, thank you. Our sanitarians, we do have some positions. You want to throw your positions? That's true. We do have some that are just challenging, either because of the pay scale or other things that people want practice or other things. So we do have some challenging positions. I've been talking with our HR team about figuring out individual sort of solutions to what are the barriers for particular positions.
Okay.
We've had some success in getting past that, though. So what we just said about moving the sanitarians and looking, well, what do we actually need this person to do? Is it an actual sanitarian, which is very hard to find, or is there some other designation that we could do that we could find that would work for the same thing? And it turns out there was. So we're trying to problem solve around each of those difficult to fill positions.
Okay, pivoting again. In fiscal year 24, 2 federal awards issued to DC Health were a part of the fiscal year 23 DC single annual audit, resulting in 3 findings for the SNAP program. What steps, if any, are being taken to improve the functioning of SNAP?
So we had findings with the Women, Infants, and Children program. And one of the findings was around time and effort certification. So making sure that if staff members, if are supposed to be working on OCFO, on women, infants, and children, that we're talking with our OCFO team, and they know to pay those people, in their paychecks using that women, infants, and children funding, so that we don't have people.
So it seems like it's more of an operational
Yes.
fix working with OCFO.
So we are working on updating our standard operating procedure and then training all of our managers on that. We also had an audit finding that was a kind of a result of COVID. When during COVID, we could certify participants without requiring them to produce documentation. And so we needed to turn off that feature in our eligibility system, which we did. So we had, yeah.
And so it's your anticipation that there should be no lingering findings from the
no.
ones that had already been identified?
Yeah.
Got it. Chairperson Henderson, I have 2 more questions. Okay, and I'll still stick around. But while we're in the flow, pivoting again, it appears in your responses that the levels of severe maternal morbidity increased over the last 4 years, from 259 out of 10,000 deliveries in 2019 to 415 out of 10,000 deliveries in 2023. And there's a 2026 target of 233. So we've gone from 259 to 415 with a target of 233. Can you just talk to me about how realistic that is and what steps are being taken to address those rates?
So I hope someone is here, but so we'll talk specifically about that. Our approach of looking at 1 year and then the next year and then the next year is not a very statistically defensible position.
Okay.
Things flux. So looking at averages over time, at a rolling average over 10 years, because 1 year versus another is not as informative about what the underlying reasons might be, because there is change from year to year. So just, I want us
So
to
I'm
be
hearing you
careful
say
about
that to
the,
say that you do believe a target of 233 is possible in 2026.
sure, it's possible, because I don't know what the rise was based on, or whether or not it was a blip,
Understood.
or whether or not this is a rolling thing. So we'll look at it and give you a sense of why that target was picked and where that sits in the longer trend. But just a few years at a time isn't as informative as it
Okay.
appears on paper. But what are we doing about it?
Yeah, and we've also, I think, intensified our efforts around it. So with our perinatal quality collaborative and collection of data, I think there's been a lot more attention. And so it's possible that we have a temporary, increase in the rate as reporting is being improved, and that we will see, as we are implementing interventions, we will see the rate continue to go down, because we are seeing some significant improvements with our PQC partners with interventions.
Okay. I would just throw out there was legislation that sought to provide housing to moms in their second trimester via DHS and DCHA. And there was severe pushback from other parts of the government, because that would upend our housing system. I don't buy that. And so I'm just saying, if there is an opportunity for you all to sync in your efforts with DHS, I think that could be really beneficial.
Yeah.
Awesome. One last question. Why is the target number of at-risk families with children under the age of 5 enrolled in home visiting or home visiting support services set at 145 families for 2026 when 300 families were enrolled in 2023? Is that merely a budget capacity issue?
I need to look at that. That might be a typo, because I thought, let me look at that.
Okay, so if you could look at the number of at-risk
Yes.
families with children under the age of 5 enrolled at home visiting, the number we saw was 145 families for 2026.
Yeah, I think that might be a mistake. We'll look back at that and
Okay.
update you.
Awesome.
Yeah.
Thank you.
Yeah.
And thank you, Chairperson Henderson, for being so generous.
Thank you. Okay, let's talk about cottage food, street vending. So I will note that Councilmember Nadeau cannot be here today because she's chairing her own hearing, but she asked me to ask some questions. I'll note those. This one is mine. Okay, 23 cottage food businesses applied for certification at FY24, but only 16 were approved. What part of the process are most of these applicants not meeting the criteria for approval?
So it varies. So sometimes the foods that they want to do don't qualify as a cottage food. They may be potentially hazardous. And then other
Wait, the
times,
food is hazardous?
potentially hazardous.
Oh, okay.
Yeah, so all of the cottage foods, they have to be non-potentially hazardous.
Got it.
So sometimes it's that, and then sometimes they decide they want to go a different path. They decide, well, since I can't do this, I will just vend rather than be a cottage food operator.
Okay. Do we know how many people in the district have a cottage food license?
I think it is 39 that are registered with us right now,
Okay.
approximately 39.
All right. Similarly, 90 businesses applied for a shared kitchen license and only 34 were approved. What's the big hiccup there in terms of folks not getting approved?
Space. So I'll give you an example. We had one facility that wanted to be a shared kitchen. The facility was actually only 500 square feet. When you add the refrigeration and tables and things like that, it was approximately 250 of, working space. So we have situations like that.
That's like a studio.
Yes, extremely small.
What's the minimum square footage?
We don't have a minimum square footage. Our plan reviewers have a calculation that they use that will tell you how many people can be in the kitchen depending on the square footage.
How many people can you have working in there depending on
Yes,
space available?
correct.
So if there's only 250 available space,
Most likely it's going to be about approximately
Two
maybe,
people.
maybe 3 people. Yeah.
okay. Okay, Councilmember Nadeau asked me to ask this one. She said the Festival Center in Adams Morgan has a commercial kitchen. I have seen it, which is a good option for vendors in Columbia Heights to prep food. However, Councilmember Nadeau said she's discussed this with DC Health and the Festival Center has been unable to get a commercial kitchen permit. Have you looked into this?
Yes, so we did meet with her, I guess, in the fall, and we followed up. So we did, that's one of the facilities that is extremely small. So we did, they are licensed, but we only approved, I think, what was it, 2 or 3? It was 2 or 3, 2 or 3 people in there at a time because it was so small.
I mean, it's not a cafeteria, but like, you can move 2 or 3 people. That is probably the maximum number of people that you can get in there. They do have a lot of high grade equipment though. So, okay, so it's good to know that they have been approved, but for a limited number of people. So if we could let Councilmember Nadeau know that part. I do also want to just note that if we want more of our small businesses to cook in commercial kitchens as opposed to in their houses, we do need more shared spaces to be approved on that front. Okay, street vending. I understand that DC Health has issued some emergency vending regulations related to the Street Vendor Advancement Amendment Act of 2023, and that final rules will be issued in June, I believe. How are you all coordinating with Department of License Consumer Protection on outreach to the street vendors about the new processes to operate?
And we're talking about micro enterprise?
Yes, micro enterprise.
Okay, yes. So DLCP has meetings with the vendor community, I think is bi-weekly. So we participate in that with them. We've also had several meetings with DLCP on how to streamline the process. We do recognize that because there's so many agencies involved that it can be confusing and cumbersome. So we're trying to streamline the process to make it as easy as possible for the applicant.
Okay. When I was talking to Director Crow, she and I talked, at length about street vending, and this was the question around like, who is the appropriate agency that perhaps we can just designate for the one-stop shop, as opposed to you got to go to DLCP, you got to do this and this and this, and then you got to go to DC Health and do this, this, and this. It could be cumbersome, especially when we're talking about someone who is just trying to do a micro enterprise, right? They're not trying to do mass production of food, but we have added so many steps and hoops that it's making it incredibly difficult. For instance, you report that 4 businesses have applied for their micro enterprise kitchen license or certificate from DC Health, and only 1 has been approved. So in those instances, what criteria are they not meeting? Like, we're 1 year into this law and only 1 person has been approved.
So we can get back to you on what those specific cases were. I can't speak to that right now. I do know that at least 2 agencies would definitely need to be involved. For the health portion would be us and FEMS.
And FEMS?
I'm sorry, fire EMS. So
why would FEMS need to be involved?
So if they have any open flames or anything like that. Yeah.
Okay.
So a lot of times that holds up the process. We're typically the last step. So when we approve you, you have to be ready to operate. So we'll inspect, but if you haven't been inspected and approved by FEMS, we'll hold on to your health certificate until you get that.
Okay. On the website, which I'll just note as an aside, which is a larger conversation for Octo, you guys have a lot of great information, but your website is terrible. Terrible. Sorry. That's an aside, but
We're negotiating with them on updating it. We've been working on designs and they have a process they're going through. and we're going to participate in that
Okay.
process.
Because, you know, Brittany's making all these nice, beautiful dashboards, but if nobody can find them. Okay. All right, that was an aside. On your website though, is there a checklist to say like, if you want to pursue this, here are the following steps?
Yes, yes, so we do have that for the micro enterprise.
Okay, and for the open flame piece, does it have that specific, like, if you're gonna do open flame, you need to go to FEMS?
I would have to follow up with you.
Okay, I feel like that's a specific designation. I don't know how many of these vendors are doing open flame on the sidewalk, but some might. And so, you know, they just need to know, helpful on that front. In terms of another kind of area of collaboration, I guess, between you all and DLCP is around food trucks. When you all are doing inspections, food trucks are considered, are they considered a priority?
Yes,
Okay.
yep.
Now, one of the things that we've had an issue with that Director Crow's team is trying to figure out how to figure out is like, we'll have some food trucks who roll up on the National Mall who have not registered with anyone, who is not licensed beyond perhaps the driver of that vehicle. Who enforces in terms of those entities not having the proper documentation or the proper inspections to operate?
So we have a collaboration. We have an entire work group. Typically, we meet and we do the real enforcement from, you know, spring to fall time. That's when we really see it. But it will be us, DLCP, DPW, some of our federal partners like Park Police. It's a cohort of people, MPD. So that's a real issue. And I think a couple of the actual explosions or fires we had was on those areas from illegal vendors. So it is a real issue. We do have an enforcement task force that we meet with regularly. So all of those agencies have a part in that.
Okay, I think we're gonna have to do some doubling down. Spring and, you know, winter, we don't really see those trucks out, but in spring and summer, they definitely pop up. And again, in sort of, I guess, anytime you eat anywhere, it's kind of, you're assuming a particular risk. But that's all we need is some story from some family from Omaha who came to the nation's capital for their family trip, who then got food poisoning because they ate from a food truck. And then nobody is going to care about the fact that the food truck was there without the proper documentation, but that it's the district's fault because they were exposed to the bad hot dog or whatever.
Yeah, last year what we had to do is we had to designate one person, particularly not all summer, but like when we had events in DC, so Cherry Blossom, you know, different street fairs, things like that. It's just to be in that area and walk up and down that Independence Ave area, because literally we'll go out there with the task force. We will enforce, they'll leave, and as soon as we leave, they're back. So it's resource intensive.
Yeah. Okay. All right. Here's what I want to ask about street vending, and I'll ask the same thing in terms of Director Kerr from DLCP. It's been a year since we've had this law in place, and it is hard for us to evaluate whether or not it's been effective because there have been so many hiccups in terms of people being able to get the proper documentation to do it legally. And so hopefully by budget, so let's say April time, can Dr. Bennett, these agencies come together and talk about like, how do we do this better going forward in the next 6 months? Because basically we have the advocacy groups who are basically accusing the government of just stonewalling because we don't want to do it. And so I feel like there's a better way to do this. We just need to figure this out.
Yeah. So we did have, in the fall, we did have 12 events to help register people. It wasn't very well attended. When we did meet with Councilmember Nadeau, we did come away with a to-do. And one of the things we're going to try to take those events, instead of having people come to our building go to their neighborhood. So that's what we're going to try to do in the spring. But I will push back a little bit. A lot of times when you have, and we experienced the same thing when Department of Health used to have medical marijuana, when you're trying to get people out of the illegal market and into the legal market, there are challenges and pushback.
And I'll add that we followed up with every single applicant for the micro enterprise home kitchen. There was about 13 people who started an application, and our staff, our multilingual staff, talked to all of them, tried to understand what they're interested in. Most of them were not actually interested in the micro enterprise home kitchen license. They had mistakenly applied for that for something else. We actually talked to folks, I think only 2 or 3 of them were actually interested, and we sort of held their hand to walk through that process. But I think to Arian's point, both the nature of moving from this gray market into sort of a more legal market means you now have to pay taxes, you have to qualify with OTR, you have to have one of the very few attractive vending zone locations. Like I live in Columbia Heights, everyone wants to be in the exact same 5 square feet. And I think when the realities of that came into play, people were no longer interested. And so I think trying to understand what the purpose of this license is, this permit is, where it should apply, and how we can fit that into the continuum of how can someone move from cottage foods at home into opening their own restaurant someday. Where does this fall and how can we help that process? I think that's where we're sort of wrestling with right now. But I know DLCP meets with the vendors and the advocacy groups on a monthly basis. Our team has offered to be there anytime food comes up. My understanding is also most of the vendors are not interested in food because it's harder and it's more of the, knickknacks and clothing and other items.
Which has also caused, this is not y'all's problem, but it has caused a little bit of issues just in general, because I think when this was first pitched in terms of let's do regulations around street vending, et cetera, most, if not all of the examples provided were related to food. That is how we sort of got into this conversation. But you live in Columbia Heights and you go down Columbia Heights, that is not the majority of what is being vended. And I think that has also taken a shape in terms of public perception about the pilot in general, because I think food was what folks thought we were doing, and that is not what is happening. Okay, last topic, animal control. I'm not gonna call it our favorite, but it's something we've been dealing with for some time now. Okay, so my understanding is that the new shelter location at District Village is temporary and that the district is still looking for a more suitable permanent location. Although I was at a hearing in one of these prior weeks where someone who's not a part of your agency was like, no, that's the new location. And I was like, nope, that is not what has been communicated as the permanent location. So can you talk a little bit about the ongoing conversations around identifying a more permanent location that is more accessibly located?
So I think I myself have been to 10 or 11 places, but once we were in crisis mode of losing one vendor and the overflow space that they provided and needing to have, if not immediate, very, very soon in construction timeline, a place to put animals, we have shifted our attention to making sure we're okay right now. So the search for where we'll end up has actually been put on hold while we try to get open what we need to be open immediately. Any future place will take some time to design, build, and open. And we're open to that conversation once we have a place to put animals that is fully finished.
Okay,
So we can reopen that conversation, but probably not for at least a month.
Okay, at least a month is different than you saying, let go of those capital dollars that we set aside there. Like, you want to keep your money, yes?
I do.
Okay.
Whatever we end up doing, whether it is satellites, or I've had people who ask me, couldn't you just have 3 or 2? There's a conversation to be had, but we cannot, we need to have a place to put animals, and we don't have adequate space at New York Avenue, and we need that space to be ready really a few weeks ago, but now would be good. So we're right at the point where we have that, and we can see how that operates and get them established, because they've only been our vendor for 6-7 weeks. So we had to rethink the way in which things were happening because circumstances changed around us. And so we are focusing on the most immediate need, which is to have a functional animal control system with space to put the animals that they bring in. And then we can start a conversation about what better would look like. But I need to focus our attention on good right now.
Okay. Okay. So I was troubled to see that the former contractor had significantly increased their euthanasia rate. Q1 of FY 2025 was 369 animals. When it had only euthanized 365 animals over the entire prior fiscal year. So Q1, they did more than they did the entire year prior. So what steps are you all taking to enforce the no-kill requirements in the new contract?
So we do know with the new contractor that our live release rate has gone up even over the average before, not let alone compared to last quarter, which it is remarkably much better than. Let me find that actually. I'll tell you exactly what the numbers you have.
Yeah, so I do want to apologize. The numbers that you got were a typo. So
Yes.
For FY 24 for the previous, for domestic, it should be 1865. So we do apologize for that.
Wait, are we talking about the same thing?
You said euthanasia, correct?
Yeah. What did you say? Euthanasia,
18, it should be 1865.
for FY 24.
Correct.
Okay.
Yes.
All right.
Yeah,
Okay.
so I apologize for that. And then for wildlife, for FY 24, wildlife should be 418.
Okay. We can make that adjustment. Okay. So that was a little
Sorry.
alarming there.
So, but you are right, the rate was higher with our past vendor than even if you compare January to January. We have gone from, I think it's 87 or 88% now to up to 92. So that was one of the things we wanted with our new vendor was their no-kill reputation and skill set, and they have demonstrated that.
Okay. The former contractor also only spayed 95 cats in the catch and release clinic, which was down from over 3,000. What are the requirements in the new contract for spay and release clinic frequency?
So they are required to do the spay and release of animals that come to them or that they have picked up. That number will vary. We're still, there was some question about the cleanliness of the data, meaning separating things that they were doing as an institution, our former vendor, and things that were done under our contract. So I don't have great confidence that we know what those numbers were, but we're still looking at what the pace of that will be based on the need.
Okay. I think just to be clear, we had required clinics. So like,
yes,
come one, come all. So that's what I was wondering. Do we
That's why I'm
still
saying I don't know the
require?
number. They're required to do clinics.
They are.
Yes.
That's what I was saying. How many are they required in terms of frequency?
I don't remember the number,
Okay.
but they're doing them regularly. They've already done more than one.
Okay. So new contractor, interesting transition of terms in terms of doing it the first of a calendar year in the middle of a fiscal year. None of it was ideal.
Yes.
There was a representative who testified on Monday, so we were able to answer some of these questions and it also bring to the attention that we have received some complaints thus far, but as with anything new, that is likely to happen. And so one of the things that we kind of got some clarification around is who's picking up the phone after 5 o'clock? After 5 o'clock. So, our understanding is that if someone has an emergency with regard to animal control, there is an opportunity for them to call a hotline 24 hours. Now, what, I think his name is Aaron. Okay, Mr. Aaron. I think his last name is Johnson, but I can't recall.
Yes, you're
I think Johnson? Okay, great. There's a lot of people. So, he stated that their staff is there from, I think, 8:30 to 5 or something semblance of a normal business hours. And then after 5 o'clock, it goes to a call center for them to triage and determine what is an emergency versus what is not. is the call center contractor a sub of Brandywine, or is that a separate contract with DC Health?
We don't have a separate call center contract, but we'll have to talk to them about how they're managing that. It is in their contract to do. It doesn't prohibit them from using a sub to do it, but we'll have to have a conversation with them about that and get back to you.
Okay. And then also I would ask though, from an oversight perspective, that DC Health sort of look in around is a lot of the complaints we were getting is that no one is picking up.
Okay.
Right. So if we have contracted with a call center and taxpayer dollars are paying said call center and nobody is answering, that's a problem.
Yes, it is.
And we need to get that corrected sooner rather than later. The other thing is around accepting stray animals. Now, when I talked to Mr. Johnson, he said, well, you know, ideally we'd like to keep the animal in community if we can. One of the things that I'm concerned about is that people will think twice now about identifying or picking up a stray if it is not a temporary situation, if that makes sense. Right? So
Yes.
I saw a dog, oh, cute dog, I don't want you to get run over. Oh, just come with me while I call. But then when I call, they're asking me to hold on to the dog for 2 to 3 days until the owner can be identified, maybe, maybe not. I might not pick up the pooch the next time. And so, you know, how are we going to sort of manage this? And I think this is going to be a transition for the community because this has not always been the case. Is this a philosophical thing in terms of Brandywine, or is this a space capacity concern?
So part of it, particularly when they first took over, was a space capacity. I am happy to announce that they're in the transition now to DC Village, so we'll have much more space. They're moving in as we speak. But we do have regular meetings with Brandywine, weekly meetings with them, so we'll definitely bring that up.
Okay. Thank you. We'll follow up on that. Councilmember Nadeau also wanted me to ask, so the Humane Rescue Alliance previously worked with the Office of Clean City on management of pet waste in public spaces and installing bag dispensers. Was this part of the previous animal care and control contract? If so, is Brandywine taking over this service?
It was not, so that must be something that they were doing as a nonprofit member of the community.
Okay, so does DC Health have any role in the management of pet waste in public spaces? Or is this rodent abatement now? Or I don't know.
Yep, so we're asking our state vet to come up, Dr. Del Vento.
Good to see you.
Good afternoon.
Oh, we just got to hit the button.
Good afternoon. My apologies for my voice. Hopefully you can hear me okay.
Yes.
For the record, Dr. Vito Del Vento. Can you just repeat the question? I want to be sure I answer it correctly for you.
Yep. So we were asking, not doctor. Ooh, you're the doctor. Councilmember Nadeau had asked a question around, does DC Health have a role in the management of pet waste in public spaces? Or how does this fit into the larger rodent abatement efforts? I don't know if pet waste causes rodents, but. Well, it does. Okay, great.
So the district essentially collaborates with other agencies to manage this. And so, of course, rodent abatement is with our administration. And so we'll work with them on some of those issues if there's a problem. And often we'll go out and do inspections together to try to sort out some of those concerns. The waste in public space, however, rests with the Department of Waste.
DPW.
And
Okay.
so we work with them as well to be sure that messaging is out there, signage, things of that nature. And if we know that there's something that's problematic, then the animal control officers are tasked to sort of patrol those areas and see if they can be a presence and help sort of educate people and essentially reinforce, picking up after your pet.
Okay. I guess maybe we should ask this question of the Office of Clean City. So, I mean, I have a dog. I walk him. And it's great that we have these dispensers in public spaces. They rarely actually have any bags in them ever. So it's like, well, whose responsibility is it to refill said dispensers? But it's not part of the animal control contract, which is what Councilmember Nadeau was asking. And so we can report that back.
Yeah, that is not. But again, we try to collaborate with folks. Often the public spaces that are of concern, and rightfully so, are children's ball fields and areas where, especially this time of year where there's not activity, folks then tend to sort of take that on as, well, this is a great place to let my dog run. And then it is a problem. So we want to be sure that we're not allowing that, so that when those parks sort of become active again, they're clean and there's not an issue for, the folks using them as well as the public health concerns.
Yeah. I've seen that happen a couple of times.
Yeah.
I'm like, the dog park is like
Right.
right across the street, just right there. But okay. Let me ask in terms of hiring for the animal control positions. So this is not the care piece, but the control, are the officers, who do the investigations, et cetera. Are we fully staffed?
Yes, so Brandy, so that falls under the contract, so we are fully staffed with that. As far as some of our other services animal, we're in the process of onboarding a specialist.
A specialist? Say more.
So not necessarily for the, dog enforcement and things of that nature, but like for dog licenses, for mosquito surveillance, for that sort of thing. So we hired them, we selected them in a hiring event almost 2 weeks ago. And so now we're onboarding them.
Mosquito surveillance.
Yeah, we do a lot. Yeah. So Wes, now you want to speak to that? You want to speak to that, Dr. Del Vento?
I feel like I think I knew you guys did this because we had a constituent once who had a complaint about the neighbor and their pool.
Yep, and we'll issue mosquito dunks and put them in where standing water is. Yes.
It's all part of the arbovirus surveillance program. And so there's a surveillance on the mosquitoes for specific diseases, as well as supporting mitigation to problem areas.
Okay. I also have another email from a constituent who had a suggestion about how genetically modified mosquitoes can help deal with some of our issues. Anyway, now I know who to forward it to, because I was like, I don't know, but okay, great. Well, we've come to the end. I know. No, seriously. One thing though, just on animal control really quickly that I just want to mention. Last year there was a incident where I think one of your officers were involved in, they were going for an investigation and then the person fired shots and
Yes.
it was a whole to-do. And so I do want to express appreciation. I know sometimes when people think of like, oh, animal control, it's not that big a deal, but
It
they
has been.
sometimes are put in harm's way in the betterment for the purpose of the public good, as well as for the protection of these animals. And so I do want to express appreciation because that was a terrible situation that once we realized what the origin was, most people don't realize that was what was happening.
Well, mistreatment or the way in which you interact with animals falls in line with a lot of other antisocial behaviors that people may have. So they're not always the safest people to try to interact with.
Yeah. And I'm glad that there was an MPD officer with your agent there. But okay, I don't have any more questions.
Well, thank you for this.
Well, actually, that's false. I do have
Oh.
follow-ups that we're going to send. I don't have any more live questions. I do want to thank you and your team for engaging in this very robust conversation. I learned a lot of new things. This was super helpful for us, and also hopefully for the public, clarifying on some of the questions that they may have had about the performance of the agency. I mean, for those who are watching, we covered a lot, right?
Yes.
Of issues, even ending on a conversation about mosquitoes, which people don't think that necessarily fits in the DC Health portfolio. For the public witnesses who want to submit testimony but still haven't done so, you can submit testimony for the record until March 12th at 5:30 p.m. You can submit written testimony on the council hearing management system website, dccouncil.gov/hearings. The next performance oversight hearing for our committee will be on Wednesday, March 5th. We'll hear testimony on several DC Health professional licensing boards. So we're doing Board of Medicine, Board of Pharmacy, Board of Psychology, and the Board of Dentistry. All of these are great boards, but we've also had issues arise in all four of those areas in their professional capacities. If a public witness is interested, in testifying, you can go to the council's website and sign up for that. But for today, the time is 2:16 p.m. Thank you. Appreciate you all.
Well, thank you for having us. We really want to talk about the work and we want to be as transparent as possible. You'll hear more from us even when you don't ask.
Thank you. Thank you, everyone.